A very good morning to everyone once again. Welcome to session 2 of the Singapore HIV Congress 2021. We appreciate you taking the time off your busy schedules to join us today on a Saturday, wherever you are. We hope you will find this session to be fruitful and engaging. My name is Sally and I will be your MC for today. Without further ado, let us welcome the Director of the National HIV Programme, Associate Professor Sophia Archuleta, to give the opening address for today's session. Prof. Sophia, whenever you are ready, please.
Okay. Thank you, Sally. Good morning, everyone. Welcome back to day 2 of the Singapore HIV Congress 2021. It is going to be an interesting day today. What we have planned for you is, in the first part of the morning, a deeper dive into the HIV continuum of care here in Singapore, going all the way from testing to the fourth 90. And after the break, we'll move on to other aspects that are also very relevant to care and the fourth 90 itself, such as aging with HIV and stigma in our region. And we're very pleased to have with us our neighbors, Professor Adiba and Professor Rina, who will be anchoring the section after the break. Stigma, as we know, has impact across the continuum of care. So it's impossible to be having an HIV meeting or having meaningful conversations around HIV treatment and prevention without addressing this. And it's because of this, the National HIV Program is extremely proud to have worked together with stakeholders from community organizations like Action for AIDS, the clinical programs at NUH and SGH and other partners like SNF, and of course the Health Promotion Board, to put together a very comprehensive destigmatizing campaign that was released last week. Actually. So some of you may have seen the ads across MRT stations, and there are also some videos and other sharing by influencers on social media that go along with that. And the message this year is very much that of HIV positivity, and I hope we'll carry that with us, not just for World AIDS Day, but throughout the year as we think about those who are living with HIV and are affected with HIV. We'll share with you now a couple of the videos that have been put together, and then we'll move on to the Congress proper. Thank you.
Thank you, Prof. Sophia, for the opening remarks. I am sure we will have another exciting session today. Please allow me now to invite Dr. Loh Jiashen on the screen, who will be the moderator of the first segment today. Dr. Loh is an infectious disease physician at Farrer Park Hospital. He had previously served as a consultant in Sengkang General Hospital from 2016 to 2020, before leaving for private practice earlier this year in January 2021. Dr. Loh will now lead us through the first segment for this morning to discuss on the 4 90s of the HIV care cascade. If you have any questions for any of our speakers during the session, you may leave them at the Q&A box, and we will try our very best to answer them all during the Q&A session. Dr. Loh, you may take over. Thank you.
Good morning, everybody. To the HIV Symposium. Today is 4th December. We are very fortunate to have 5 esteemed speakers speaking to us. The theme of today's talk is the 1990, the cascade, and hence we will probably have one speaker for almost each of the 90. Without much further ado, I'll introduce the first speaker. First speaker is Dr. Choi Cherry. She's a consultant infectious disease physician at the NCID. She received her medical training at Women's School of Medicine and got her MRC in 2016. Having an active interest in HIV clinical care and research, she's a member of the National HIV Programme and Deputy Director of NCID Clinical HIV Program. She's also actively involved in education and as Lee Kong Chien, Medicine, adjunct teaching faculty and NUS medical faculty member. She'll be speaking to us about for the HIV testing recommendations in Singapore. So take it away, Dr. Choi.
Okay, so good morning, everyone. It's really my pleasure today to be able to talk to you about our HIV testing recommendation. This is the first time we have a national recommendation for HIV testing, and I hope everyone will find it useful. So this is the overview of the topic that we'll be going through today. We'll be talking about why is testing important, who we should test, consent-free test counseling, testing algorithm, and post-test care. So I think first of all is the question of like why we even come up with recommendation for testing and why it is important. And one thing to note is that we know that with highly effective ART, it's actually improved the life and the life expectancy of people living with HIV infection. But despite that, every year, there's still 1.7 million people that are diagnosed with HIV infection, and 680,000 people died of AIDS in 2020. Now, in order to actually have individuals be linked to care and have treatment, as an important first step of the care continuum, HIV testing is essential. So individuals really need to know about their diagnosis before they can be linked to care, engage and retain in care, and started on antiretroviral therapy. And then why we're putting so much emphasis on this is that we want to achieve the end goal of virologic suppression. So it's only really with virologic suppression that we can reduce AIDS-related morbidity and mortality, as well as to improve the quality of life. And in addition to this, individuals who actually know their diagnosis are less likely to transmit the virus onward. And that's one important reason why individuals need to know their diagnosis. In addition to that, being initiated on treatment reduces the risk of AIDS-related event or serious non-AIDS related death by about 50%, and it also improves immune recovery. And because of all these benefits, everything a lot of people here would know that the UNAIDS actually started the 90-90-90 target, which is meant to be achieved by 2020. So 90-90-90 being the 90% of individuals diagnosed who has HIV infection know their diagnosis, 90% of those who know their diagnosis are actually started on treatment, and 90% of those on treatment attain sustainable virologic suppression. As I think in session 1, Dr. Hong has presented recently, we're just shy of the mark. In fact, globally, we're all just shy of the 90-90-90 mark. So as usual, once that passes, we'll start a new target or a new goal. So now instead of 90-90-90, there's the 95-95-95 target to be achieved by 2030. But why is this target so important, and why do we keep putting so much emphasis on it? So you can see by the graph on the left, via the green line, if let's say we do not make an attempt to diagnose individuals as well as start them on treatment, you can see that the rate of HIV infection will just steadily increase, and this will be corresponded by the number of AIDS-related death, which is shown by the red line for the graph on the right. Whereas if we attempt to diagnose individuals and put them on therapy and therefore bring them to virologic suppression, eventually the number of new HIV infection will fall, and therefore corresponding fall in the number of AIDS-related death. Now, but although this is important in Singapore, we do always have a bit of problem with the first 90. We have always, no, I wouldn't say always, but we have achieved the target for the second 90 and the third 90. This is in 2018. As you can see there in 2018 for the first 90, we haven't quite hit it, it's 80%. Dr. Hong has already presented this in the first session, in which once again in 2019 for the first 90 we're at 82%, whereas we're doing very well for the second 90 and the third 90. So where is HIV testing done in Singapore? In addition to routine healthcare, these are the following places where it's frequently done. So there's the voluntary opt-out screening program that is done by MOH since 2008 to kind of increase the testing detection rate and try to reduce late-stage diagnosis in adults in restructured public hospitals. 10 clinics currently provide anonymous HIV testing. Anonymous testing services are also provided by community-based organization, and perhaps in the future we will have HIV self-testing. If we look at the number of newly diagnosed cases in Singapore, there's actually been a decline, which is great. So between 2007 and 2017, it's about 400 and 500 cases. And as of 2020, it's currently 261. We think this could be due to a number of reasons. It could be due to a lot of campaigns that espouses conventional behavioral prevention therapy, but also because more and more patients are being started on effective treatment. And also some clinics in Singapore have also started providing pre-exposure prophylaxis. But despite the numbers actually coming down, it is still important to actually focus on HIV testing. And that's because if you look at Singapore's sources of HIV diagnosis, more than half actually are diagnosed in medical care. And that's not really what we want to see, because that means that they are actually symptomatic at the point of diagnosis, and this usually happens in AIDS. 24% are diagnosed in routine programmatic screening. So this includes things like hospital screening, screening for individuals who have sexually transmitted infection, as well as spousal contact. Only 16% are self-initiated, 8% are others, refer to things such as employment screening as well as insurance screening. So back to the sources of diagnosis under medical care, because slightly more than half are diagnosed in medical care, it's therefore not a surprise that slightly more than half are also diagnosed at late diagnoses. And like I said before, that's not what we want. The earlier individuals are diagnosed, the better, because we can then prevent AIDS and related morbidity and mortality. We can also prevent onward transmission. So now that I've gone through why we need this recommendation and why testing is important, we will now go into the recommendation proper. When coming up with this recommendation, we actually refer to international guidelines from CDC as well as WHO to guide our own. Now, for initial screening, who should be screened? Actually, all persons above the age of 21 years old should be offered HIV screening at least once in their lifetime, except for females above the age of 65 years old. And the reason why we say this is because in accordance to CDC guidelines, and actually even in UK guidelines as well, healthcare work providers should actually initiate screening unless the prevalence of undiagnosed HIV infection in their patients has been documented to be less than 0.1%. I know some of you might be thinking, why so specifically at 0.1%? So this is actually a modality of public health screening. We're always talking about whether it's cost effective to do a screening or not, whether it's actually for cancer or for HIV, where you implement a test on a population that's asymptomatic and you would like to get a certain yield or a certain number of people who are diagnosed. And in terms of HIV, it is most cost effective at seroprevalence of more than 0.1%. And in Singapore, the only population that have a seroprevalence of undiagnosed HIV infection less than 0.1% are females above the age of 65 years old. And therefore, for this population, we do not routinely offer screening unless they have risk factors. In particular, for initial screening, individuals we should pay particular attention to the following groups. I have grouped them into 3 groups. So they are the medical conditions, special population, and others. So under medical condition, we have tuberculosis. So HIV increased the risk of TB by 24, and the rate of HIV-TB co-infection is 4.9%. So it's fairly high, and therefore every individual with TB should be screened for HIV. We also have sexually transmitted diseases such as gonorrhea, chlamydia, as well as syphilis. We have AIDS-defining illness and symptoms suggestive of acute HIV infection. I will go through these symptoms later so that everyone can know more about them. In terms of special population, all pregnant women should be offered HIV screening at each antenatal visit. And in terms of others, all individuals who have high-risk behavior for HIV transmission should be screened. And I will go through what are these high-risk behaviors in a minute. For AIDS-defining illness, I believe many people are familiar with this. This can also be easily found on Google. But if you have a look at the ones that are in bold, these are the very common AIDS-defining illness. So this includes candidiasis, cryptococcus, CMV disease, TB, PCP, as well as toxoplasmosis of the brain. So that's on one end of the HIV spectrum. What about the other end, the earlier end that people don't often think about? So this is a study of 34 individuals in Singapore who were acutely infected with HIV infection. If you see what the most common symptoms are, the top 3, which are fever, rash, and diarrhea. I know what everyone's thinking, it's quite non-specific. There are also other things such as weight loss, anorexia, as well as swollen glands. If you look at the signs, the most common ones are lymphadenopathy, rash, as well as tonsillitis. And so if we think about the most common top 3 symptoms, which are fever, rash, and diarrhea, basically it just sounds like dengue. So we have actually done a prospective cross-sectional study in NUH, Tan Tock Seng, as well as Alexandra Hospital to identify seroprevalence of acute HIV infection among patients who have dengue-like illness in Singapore. Basically, individuals who have 2 or more symptoms of dengue fever were identified and they are offered HIV testing. And out of the 140 participants that were recruited, 3 were actually identified to have acute HIV infection. And this brings us to a seroprevalence of 2.1%. Now, this is higher than some of the other studies that's done in, let's say, USA or even Uganda. In this country, they use acute mononucleosis-like syndrome instead. So that's also another descriptor of acute HIV infection, which is there's a acute mononucleosis-like illness. And their seroprevalence that is stated in their studies is usually about 1%. Potentially, it's because the population in this study is fairly small, and that's why seroprevalence appear maybe falsely high. But nevertheless, I think the main thing that I just want to emphasize here is that if you have an individual who have an illness that looks like dengue fever or looks like acute mononucleosis, but your lab test does not reveal these diagnoses, then I would really encourage everyone to really make a risk assessment and offer HIV screening, because this could be acute HIV seroconversion illness. If we were to miss individuals during this period, the next time they present can be several years later when they present with AIDS instead. And once again, there will be an impact on individuals' health, and we would have also missed the opportunity to prevent onward HIV transmission. So I've talked about who should be screened initially, and so now who should actually have repeat screening. So individuals who have high-risk behavior or who are this population should be screened at least annually. And of course, there can be more frequent retesting, 3 to 6 monthly, based on individual risk factors. So who are the individuals who actually require repeat screening? Once again, I divide them kind of into 3 groups. There are the medical conditions, there are drugs and other medication, and then there's the others as well. So under medical condition, again, if they have symptoms, anytime they have symptoms that's suggestive of acute HIV infection, we can offer screening. And of course, if they have sexually transmitted disease, we should offer them screening as well. In terms of drug and other medication, individuals who have history of drug use or engage in sexual activities under the influence of alcohol or other drugs, or if they are partners of such person, should be offered regular screening. And those on pre-exposure prophylaxis should be offered regular screening as well. In terms of high-risk behavior under others, sexual partners of HIV-infected persons whose viral load is above the limit of detection, especially if it's more than 200 copies per mil, should be offered screening. Those who exchange sex for money or partners of such person, and persons with multiple sexual partners. Now, we're going through a few conditions for initial as well as repeated screening. It's just worthwhile to just remember that there are some conditions that are associated with HIV infection. And this can be, for instance, dermatological condition here. On the left is seborrheic dermatitis. So among the early HIV, persons with early HIV infection, about 35% of them can have seborrheic dermatitis. And those with late-stage HIV infection, it can be up to 85%. The next one in the middle is actually herpes zoster. This is fairly common in elderly patients, but actually for individuals who have HIV infection, they do have a slightly increased incidence compared to the general population, although the use of ART has actually reduced this incidence as well. If you see this in herpes zoster in actually younger patients, do actually really just consider the diagnosis of HIV as well and offer screening. And on the third is psoriasis, which can sometimes be the presenting sign of HIV infection. Typically for patients with HIV presents with psoriasis, it's very severe psoriasis. So once again, these are just things to consider. So now that I've talked about when HIV screening is required, what about when HIV screening is not required? So actually, unless required by prevailing legislation, such as the Immigration Act, employment-related screening for occupations that do not involve exposure-prone procedures does not require HIV screening. And this is a problem in Singapore, in which we have a lot of employers who actually require HIV screening of their employees, even though they have no impact on the occupation whatsoever. It is a form of discrimination that we're still working very closely with our partners to counter. Now, if you think about exposure-prone procedures, we're talking about invasive procedures where there's a risk of injury to the worker's hands or to the worker, resulting in the exposure of the patient's open tissue to the worker's blood. So just by this definition alone, it actually really limits the occupations that meet this criteria. And mainly, I think we're thinking about healthcare procedures. So this could be procedures where the worker's gloved hand is actually holding sharp instruments such as scalpels, or where the worker's gloved hand is exposed to sharp tissues such as bone or teeth in a confined space or confined anatomical space where the hand or the fingertips may not be visible all the time. So once you have decided who should be screened, the next question is like, what should we do after that? So there's actually a need for consent and pre-test counseling, but not everybody, perhaps. So there's two groups we think about: those where pre-test counseling is necessary and those where pre-test counseling is not necessary. For those who are necessary, we're talking about first-time testers. We're also talking about individuals who are not sufficiently educated on the implication of HIV testing. Well, for individuals where pre-test counseling is not required, we're talking about those who are regular testers and low-risk individuals during the course of clinical care. So basically individuals who do not meet the criteria that I have mentioned earlier. The reason why we actually have this two groups is that we don't want to provide unnecessary deterrence to HIV testing. We do really want as many individuals as possible to be tested for HIV. So how do we approach screening as well as testing? So first of all, for counseling wise, it must be done voluntarily, and an individual must have knowledge that HIV screening is being done. For individuals who require counseling, it must be done in a space that respects their privacy as well as confidentiality. And for individuals for whom English is not their first language, we need to ensure the competence of the interpreters in providing any language assistance to individuals. What do we actually counsel them about? So we tell them about what HIV infection is, and they need to know the implications of both a positive as well as a negative test result. If they are non-Singaporeans, they need to be made aware of the restrictions on long-term pass, residencies, and other immigration matters in the setting of a positive result. And individuals should be given the opportunity to ask questions, decline testing, or opt for anonymous testing. Now, if you're counseling an individual for a rapid HIV test, do let them know so that a second confirmatory HIV test is required before the diagnosis can be confirmed in the event of a positive result. So what if your individual actually does not have mental capacity? That really depends on whether it's a permanent or a temporary condition. So if the lack of decision-making capacity is actually permanent, then the decision to screen for HIV infection should be made by the primary physician in the patient's best interest. In this case, the caregiver should be told about HIV, educated about HIV infection, and knows the meaning of a positive and a negative result. If it is temporary, we can consider delaying screening for HIV infection until the individual has regained their decision-making capacity. But once again, I'd just like to say this is really not a hard or fast rule. For certain individuals where the HIV diagnosis, the knowledge of HIV diagnosis is paramount to healthcare, then once again, do just proceed in the patient's best interest. Just to say that there is no need for a physical consent form. Any discussion with regards to HIV testing should be documented into clinical records. If the individual declined a HIV test, once again, it's good practice to actually document this in the clinical records as well. The so-called consent for HIV testing should really be part of the general informed consent for general medical care, the same way that consent is taken for, let's say, any diagnostic test or any other blood test necessary during the course of medical care. So I'll now go through the testing algorithm and how an individual is actually diagnosed with HIV infection. So in general, blood sample will be taken for the antigen antibody immunoassay. If you have reason to believe that the individual you're testing has had very recent infection, or very recent exposure, then you can collect a separate sample for nucleic acid amplification test. But if not, following the immunoassay down the kind of like algorithm with me, if it's non-reactive, then you can consider repeating a test with a new sample after 4 weeks for at-risk patients. But if it is reactive in 2 different immunoassay, then we'll proceed on to the HIV 1-2 antibody differentiation immunoassay. So this need not be done in the same lab if the if the lab does not have this capability, it can be sent out. And once it's sent out, or once this test is done, as long as you have antibodies against HIV-1, HIV-2, or both, then this HIV diagnosis is confirmed. However, if the antibody for HIV-1 or 2 is indeterminate, then we should collect a new sample for nucleic acid amplification testing, and if it's positive, then this is suggestive of acute HIV-1 infection. Now, the reason why this is important is sometimes in very early infection, the individual may not have time to form antibody yet, and therefore the test result may come back as indeterminate. It's really important not to dismiss this and say that, oh, this is just a negative test, you don't have HIV, but really to consider very acute or very early HIV infection and to do a nucleic acid amplification testing. Just to note that the algorithm that I've mentioned earlier, it's actually really for adults. For diagnosis of HIV infection in newborns and infants up to 2 years old, this really should be done via virologic detection of the HIV-1 proviral DNA and RNA. And that's because for infants, we are not able to differentiate whether the antibodies belong to them or it's from passive transfer of maternal antibody. Lab staff are required to inform the ministry of a confirmed case within 72 hours, except for anonymous testing clinic. And the confirmation of a positive result should occur within 5 days, but ideally within 24 to 48 hours. And this is something that we're working on with our labs as well. So once the test result is out, there's post-test care. Physicians and providers of HIV testing must ensure that there are protocols to inform individuals of their test result. If it's a negative result, this can be done without any direct contact between the physician and the individual. But if there's positive result, this needs to be done confidentially and in person by physician or skilled staff. So if, let's say, the HIV test result is negative, we don't just call them and say like, it's fine, you're negative, goodbye. We really should take this opportunity to take a risk assessment for infection with HIV and other STIs. And those who are identified to have high-risk behavior should really be encouraged to go for periodic risk screening. And in addition, when we're taking risk assessment, this really gives us an opportunity to share how HIV is transmitted and therefore also provide prevention counseling and services as well. If it's a positive result, then we need to ensure that individuals are linked to clinical care, counseling, and support, as well as prevention service, no more than 2 weeks after diagnosis. Really would encourage HIV treatment center to actually optimize their referral process so that they can minimize waiting time. Perhaps even one day we can do same day kind of treatment as well in the future. Individuals also need to be counseled on the importance of early ART as well as treatment as prevention. This encourages them to go on treatment, encourages compliance as well as linkage to care. It is also very important to assess risk of suicide as well as self-harm after disclosure of results. For individuals who have been assessed to be at high risk of suicide or self-harm, centers need to ensure there are measures in place to monitor this individual very carefully until their linkage to care, and referral for counseling as well as support group should be made as soon as possible. So after counseling individual, there's also partner counseling and referral as well. Individuals should really be encouraged to disclose status to their spouse, current sex partners as well as previous sex partner. They need to know that they will be contacted by a public health officer for an index interview to discuss notifications of their partner and collection of epidemiological information. They need to also know that under the ID Act, they are required to inform sexual partners on the risk of contracting HIV, and partners must accept the risk voluntarily before engaging in any sexual activity. With that, I have come to the end of my talk. I really would like to thank the following individuals as well as groups for their help in actually coming up with these recommendations. And thank you very much.
Hey, thank you for sharing that with us, Dr. Choi. We'll leave the questions at the end of the Q&A session at about 11 a.m. In the meantime, keep the questions coming in. We'll answer them as they come along if we can, typing in. The next speaker we have is Associate Professor Dr. Matthias Porto. He's a public health physician. He's the current president of the College of Public Health and Occupational Physicians, Academy of Medicine, Singapore. He has special interest in disease prevention and control, health promotion, and primary care. He joined NCID in 2019 and as Director and Senior Consultant of the NPHEU, that's National Public Health and Epidemiology Unit at the NCID. He oversees the National HIV Registry and coordinates operations for contact tracing. He leads the EPI team to provide insights on global and local situation for communicable diseases. He's an adjunct associate professor with the Salisbury Hawke School of Public Health, NUHS, and clinical core faculty member of the National Preventive Medicine Residency Program. In addition, he provides consultancy to MOH as part of the epidemiology investigation team. Today, he's speaking to us on the impact of COVID-19 on HIV testing in Singapore. This is a pre-recorded talk. So, Sally, we can start the video. Thank you, Prof. Matthias Toh, for your enlightening talk. Our next speaker is Professor Sophia Achelata. She's the director of the National HIV Programme, National Centre for Infectious Disease, and head of the Division of Infectious Disease at the NUH Singapore. She's also a clinician educator and serves as core faculty for the National University Health System, ID Senior Residency Program. Her clinical expertise and primary interest is in the care of people living with HIV and its associated conditions. She joined the Division of Infectious Disease in NUH in 2008, where she established and led the HIV program till 2017. She was appointed the director of the National HIV Programme, NCID, in 2018. She's an associate professor of medicine at the Yong Loo Lin School of Medicine at NUH and serves various educational roles and portfolio. She's active in teaching health professionals across the entire medical education continuum. Today, she's speaking to us on the HIV care and treatment services in the time of COVID. Back to you, Prof.
Thank you so much, Jeshen, and hello again, everyone. What I'm going to try to do in this next segment is bridge the first two speakers with the second two speakers. So you heard Chewy and Matthias focus quite a bit on testing in general, and also testing in the time of COVID-19. And the two speakers after me will be speaking more about impact of COVID on services, outcomes in terms of the third and fourth 90 as well. So let's get started. This is what I'll cover in my session. And of note, I don't have any financial or other conflicts of interest to disclose. We talked quite a bit last session and also this morning. The all-important targets by UNAIDS are 90, 90, 90. Again, not to belabor the point, but we know we need to do better in the first 90. We stand at 82% and have a ways to go, especially when going forward, we start aiming for that target to be 95 and not just 90. There are some positive trends from what you heard from the speakers earlier. Our HIV notifications do seem to be dropping. On the other hand, the late notifications, the late stage notifications continue to be an issue among Singaporean residents. Now that could be potentially explained that as cases overall drop, we are left behind with a harder to reach population, such as those of older heterosexual men who tend to present later, but it still highlights that we have a long way to go in this. So what are some upcoming initiatives that are going to help in this regard? It is, after all, testing is the way that you enter the rest of the care continuum and you reap the benefits of antiretroviral therapy. So of course, the testing recommendations, I can't emphasize enough how important these are, not only to develop, as has now been done, but also to implement. So in this regard, we're very pleased that in parallel with the NHIVP's recommendations, there are community there's a separate document that's being developed by community partners as part of the community blueprint by AFA and GPs. And we really hope that these will go hand in hand in increasing our testing rates by normalizing HIV testing as part of routine health maintenance for our population. Self-testing, so increasing the options through which people can access testing, of course, is important. We heard last Saturday about how that might look like if it was available in, for example, retail pharmacies. But in the meantime, currently what's available is self-testing through online vendors and also in certain GP locations. We hope that in 2022, we'll be able to roll out a demonstration project in the public healthcare sector to complement what already exists, and again, really focus on bringing up that first 90 and ensuring that people are tested and enter the continuum of care as they should. We know, of course, that a big part and that drives behavior towards testing and is deterrent, a strong deterrent against testing, is the stigma that still exists. As mentioned earlier, having HIV positivity campaigns and really focusing on the benefits of early testing and early treatment is a big part of the strategy going forward, and this should continue as we aim for zero stigma. Hand in hand with the campaign that we discussed is also online outreach. So again, in terms of where people at risk might obtain information, so online in social media and other venues. And this is a campaign that's also going live as we speak, and leads to targeted messages and leads to free testing for people to access at Action for AIDS. Oh, excuse me. Here we go. Last but not least, how do we convey messages about accessibility to treatment and the all-important message of treatment as prevention? Also the importance of undetectable equals untransmittable, not only as a public health message of importance for people living with HIV, but as a means to reduce stigma. Looking at the cascade as a whole, as shared by our Ministry of Health colleague, Dr. Hong last Saturday, we can see it's pretty clear to see that the biggest drop occurs really at the point of diagnosis, which we've just discussed, and it remains to be seen how COVID will also impact this particular drop-off. When we talk about the rest of the campaign, there are some trickles along the way, which naturally we don't want to accept as life per usual, and we really want to focus on improving those as we go. So even though the overall goal or target of UNAIDS, which is that 73% of all people living with HIV should be undetectable, has been met, is really just by a hair, and we do have a long way to go in future. So let us, now that we've talked a little bit about testing, let's focus a little bit downstream of the care continuum. So what does the landscape currently look like in Singapore? So we have the sites where PLHIV receive care. The majority, about 90% of those diagnosed and in care, are followed up in the 4 enhanced HIV clinical programs at Changi General Hospital, NCID, National University Hospital, and Singapore General. The rest of the roughly 10% of PLHIV are cared for either by private infectious diseases specialists and some GPs in the community. In the EHIVPs themselves, there are multidisciplinary teams that really focus on holistic management, particularly of complex HIV patients. And this includes clinicians, including infectious diseases trainees as the HIV physicians of the future, and of course, nurses, medical social worker, pharmacists, and other care providers that comprehensively follow up on the patients. The sites have integrated programs to support drug adherence, positive prevention, education, support, and empowerment of PLHIV. And this also includes loss to follow-up and defaulter outreach programs. In 2 of the locations, there is also prevention and pre-exposure prophylaxis services that are part of the provision of care. So how do people access this care? Again, we've talked about testing, but the steps that relate from the point of HIV screening positive to the confirmation test being positive, to linkage of care to ART initiation, and ultimately to an undetectable status can be broken up further. So one of the ways that we've been looking at in terms of essentially making a more of an impact in terms of our UNAIDS targets is shrinking this interval as much as possible. So There are a couple of sources of data that we've been triangulating to see what our status is. So from NPHEU, if we look at number of individuals in 2020 who were linked to care within 2 weeks of confirmation, if we use viral load testing or nucleic acid amplification as the means by which confirmation is sought, then actually overwhelming majority of patients are actually linked to care. Now this could be because it's actually infectious disease specialists that are more likely to order this test. And it could be that it's done primarily in the inpatient setting or when somebody's highly suspicious of acute HIV. So it could be very much so a pre-selected population. But when we look at the majority of cases that are confirmed by Western blot, we're actually not doing very well. Only about 30% of individuals were linked to care within 2 weeks. So it's important for us to have targets so we can shrink the interval even further. From Xiaoyi's presentations, you heard that as part of the national testing recommendations, we've set a maximum of 5 days. Now, this is an improvement on what was previous, but we think we can do better. One of the ways this will be done is by the change in the algorithm so that we're not dependent on Western blot, and much like the international community, move to nucleic acid testing as the confirmation test of choice for HIV. Now that this has been changed on the national recommendations algorithm, the regulatory and operational changes can follow, and we can really shrink this first interval. In terms of linkage to care, there are other initiatives and steps that programs can take. One is for high-risk individuals, they can be linked to care even while pending confirmation, and looking at how appointments are given and what are ways to expedite first appointment for newly diagnosed patients. And last but not least, we know that rapid ART initiation leads to rapid U equals U, and that's incredibly important as well. When we looked at with our EHIVP partners in terms of how we were all working towards adherence with our when to start ART and what to start recommendations based on the 2019 and then the 2021 update of the recommendations, we can see that we were doing very well in terms of the programs selecting antiretrovirals that are part of the first line regimens, but our when to start recommendations using our window of starting within 2 weeks. We have quite a range, and it can be very difficult for programs to meet without making very purposeful changes. So this is one of the initiatives from the NUH EHIVP program offering same-day ART. Now this is does require effort and restructuring on the part of the receiving program in terms of how referrals come in, not requiring, for example, the confirmation test, and being able to have access, the referrers and patients themselves being able to have access to quick appointments when they're newly diagnosed and are eligible for first-line ART. So since the program was initiated, there have been quite good results. Out of 48 newly diagnosed individuals that were referred, you can see about 20 qualified for the same-day ART, and then the remainder were not eligible either because they were not ART naive, so perhaps not newly diagnosed, just newly relinked to care, and then barriers still remain in terms of cost and coping issues. So we do have some ways to go, and we need to tweak our initiatives further. In terms of the barrier of cost, of course, we know that in September of 2020, the standard, the first line ART drugs were mostly all of them were added to the standardized drug list. So this does make a big impact on patients, and we'll be able to watch going forward how this increases the uptake of rapid ART initiation. But coping, as you saw, is still brought up as an example of why people are not ready to start same-day treatment. And again, the issues of high levels of stigma, acceptance, disclosure to family, or housemates, for example, are barriers that we still need to have a ways to go before we can minimize and have a wider acceptance of rapid ART. I'm going to shift gears a little bit and focus on what is, of course, the other major factor that is shaping currently our HIV care continuum, and that's COVID-19. I won't go into much detail about how we think HIV itself will impact COVID-19 from a clinical standpoint, other than to say that in the early days, there was quite a bit of mixed reports from smaller studies at different locales that were showing, and it was unclear which way essentially the chips may fall. But now we know from larger cohort studies that are multi-center and across locales that probably HIV itself is not a major, is not a worse prognostic factor in terms of outcomes for COVID-19, but it's rather more advanced HIV disease, so low CD4 counts, greater immunosuppression, and uncontrolled HIV, so presence of HIV viremia that are associated with the worsening outcomes. So this is a couple of studies essentially showing this. So again, it's older age, which is a risk factor for all individuals, not just PLHIV, low CD4 counts that predict the worst outcomes. So this has led to quite clear messaging now that we can give to people living with HIV. This is what UNAIDS and WHO have put out very clear messaging that if you're undergoing HIV treatment and are clinically immunologically stable, evidence is that you are no worse off in terms of COVID-19 than the general population, but really people who are not regularly taking their medication and people who are older may in fact be at increased risk. And more important than anything else, of course, we now know that COVID-19 vaccines are the best means of protection and are, of course, safe for people living with HIV. Okay, what about the other way around? How may COVID-19 impact HIV? So there's, as Matthias mentioned, there are some concerns or potential interactions in terms of susceptibility. So will COVID-19 increase or decrease the risk of acquiring HIV? Some data that we have is preliminary, but we'll have to follow long-term in terms of how this plays out. In the Singapore context, we talked about testing. So again, testing rates themselves may be down, especially during periods that require lockdown, circuit breakers, and so on. Prevention, which we're not going to talk about specifically in this session, but there is data here as well that in the same way that testing access is down, PrEP access is down as well, and implementation of tele-PrEP, for example, are ways that this can be mitigated against. And last but not least, let's talk about treatment itself. So the major concern, of course, is the lack or decreased access to ART relating to global shortages or lockdown. Thankfully, that did not pan out in Singapore, but it was a major concern in the beginning. And whether or not virologic suppression is affected during COVID-19, either because of the measures or because of acquisition, for example, of the virus itself or of ART stockouts, is something that's been hotly debated. Again, there have been some mixed results in terms of these outcomes internationally. And this is partly because, as we know, HIV, and in this case, COVID-19, requires a syndemic approach to conceptualizing the interactions between the two viruses. And there are really a lot of socioeconomic, healthcare structural determinants that actually drive outcomes, such as viral suppression, and can lead to the mixed results because our local adaptations are quite varied from setting to setting, and individually should be monitored and evaluated. And you will, in fact, hear more about that from the next two speakers after me. So let's take a look a little bit about how the treatment landscape was modified in Singapore because of COVID-19. So for a while, the WHO has recommendations on differentiated services for PLHIV. Quite simply, what that means is it's not about one size fits all, but that services are tailored based on clinical characteristics, the context in terms of local context, healthcare setting context, and subpopulation or other characteristics of PLHIV. So in terms of how that worked in Singapore, you really want to think about the differentiated services, for example, for those who are newly diagnosed versus PLHIV who are chronically diagnosed with HIV, and then whether or not they're stable or unstable in terms of the HIV itself and in terms of comorbidities, such as, for example, diabetes, high blood pressure, cardiac disease. So it really is about thinking about an individual as an individual, and again, not a one-size-fits-all situation. This is an example from the NCID clinical HIV program. Thank you, Chen Xiang, for lending me the slides. And as you can see, in the red line, appointments or outpatient visits are represented in red, and during the different periods of the original circuit breaker and the phase 2 enhanced alerts. Again, very similar to what Matthias showed earlier for testing, there has been an impact on outpatient visits. So the differentiated management really fell around a couple of different interventions. One was under appointment management, the other related to ART supply and access. For appointment management, of course, similar to other healthcare conditions, providers had to defer, where possible, physical appointments. This was to avoid risk to patients in terms of being exposed to COVID, but also to conserve manpower in the healthcare system for the inpatient setting that was particularly under stress during the periods of the COVID-19 response. Again, this had to be differentiated with careful patient selection. So what this primarily applied to was stable PLHIV who had virologic suppression to begin with no other comorbidities of note that required for them to come in for physical appointments. In terms of newly diagnosed PLHIV and those who would benefit from rapid ART initiation, programs did not defer appointments, and those patients continued to come in as per usual, so they could be started on their therapy. There was a delinking of medical visits from lab visits, pharmacy visits, and routine health maintenance such as vaccinations, again, in order to conserve resources and avoid risk to patients, and teleconsultation became the default at NCID and other programs as well. In terms of ART supply and access, from the beginning of 2020, there's been a cap of a maximum of 4 months prescription in terms of antiretroviral therapy in case there was a supply chain impact. Thankfully, this has not happened. We did see a number of patients who used to access ART abroad, such as in Bangkok, the Thai Red Cross, and other forms of procurement who of course can't travel and have shifted to the clinical, to the pharmacies here in Singapore. And thankfully they benefited from the drop in the cost with the ART SDL inclusion. And of course, medications were able to be delivered at home so that there would not have to be a physical visit to the hospital. So is there a COVID silver lining? This question comes up a lot, I think, across both our professional and even personal lives. And I would argue that in this case, as in many others, the answer is yes. There have been numerous professional societies and international organizations, including UNAIDS, that have made the case that COVID-19 is in fact accelerating the scale up of innovative HIV service models, and this includes the more rapid expansion of what the WHO recommends as differentiated service delivery for PLHIV. Last but not least, will this lead, or should this lead to a reimagining? Again, I think the answer here should be yes. Systems for health must be sufficiently flexible and adaptive to respond to multiple pandemics, to respond to people's needs, preferences, and circumstances, and they have to be optimally equitable and inclusive. All key stakeholders really need to work together towards this. That includes PLHIV themselves, leaders, scientific, healthcare, and even non-healthcare sectors. to work in partnership to advance these strategic health aims. And finally, if we do this, we stand a chance to end AIDS and end pandemics. Thank you.
Thank you, Prof. Sophia, for sharing with us the enlightening talk. Our next speaker is Dr. Tay Yen. She'll be presenting the viral suppression data in Singapore to us. She's a consultant in the Department of Infectious Disease at the Singapore General Hospital. She graduated locally at the Yong Loo Lin School of Medicine and obtained her specialist accreditation in 2017. She has a keen interest in the management of infections in immunocompromised individuals, including hematology and oncology patients, and patients with HIV infections, of course. She's currently the director of the SGH HIV Clinical Program. So without further ado, please carry on. Take it away, Yen.
Okay, so I'll just talk a bit on the viral suppression data that we have. So before that, we all know and have experienced that the COVID-19 pandemic has impacted the world beyond imagination. As of 30th November this year, more than 261 million confirmed cases and 5.2 million deaths has been reported to the WHO. And as countries worldwide went into lockdown, unemployment soared and access to healthcare for the poorest and most vulnerable has been cut off. The pandemic has definitely threatened the progress made with HIV over the last few decades, with disruption at varying levels to HIV programs and services worldwide. So the UNAIDS actually performed a modeling study that examined the scope of prevention, treatment, and social interventions needed to achieve the targets of reducing new infections and AIDS-related deaths by 90% from 2010 to 2030. Last year, they then looked at the effects of COVID-19 related disruption on the achievement of these targets. And the charts here show the original strategy targets in the blue line, looking at the number of new infections per year on the left and AIDS-related deaths on the right. The effects of disruption lasting 3 months, 6 months, and 2 years are represented by the pink, green, and red line respectively. And the assumption that were made were that during a disruption, the rate of increase in antiretroviral therapy coverage would be half the pre-COVID rate. There would be no voluntary medical meal circumcision. 20% of the world population would experience a complete disruption of services to prevent vertical transmission, and there would be no PrEP scale up. The results indicate that there might be some increase in new infections and HIV-related deaths in the next few years, but if we can actually catch up with the service targets by 2025, we can still get back on track to what we actually set out to achieve. Despite that, the disruptions over the next few years could result in 120,000 to 290,000 excess new infections and 70,000 to 150,000 excess HIV-related deaths compared to a scenario with no disruptions at all. And HIV service disruptions occur due to many reasons. On the individual level, it was more difficult for patients to reach healthcare facilities because of disruption to public transport services, lockdown, as well as stay-at-home notices. Patients were also fearful of catching COVID-19 from the healthcare facilities, and hence you would expect that they would avoid seeking care. From the institution standpoint, there was a strain on the resources, and therefore this were reallocated from supporting HIV services to managing the COVID response. So for instance, laboratory staff may be shifted from molecular testing of HIV to testing of SARS-CoV, and the limited availability of trained healthcare workers and skilled laboratory staff. It was anticipated that perhaps restricted ART access and decreased viral load testing would occur, with a possible resultant destabilization of the rate of viral suppression achieved in PL-HIV. But in fact, according to the UNAIDS, WHO, as well as the UNICEF HIV service tracking tool, most countries, even in the resource-limited setting, did not really experience a reduction in the number of people on ART during 2020. So this graph here actually shows the percentage change in the number of people on ART. So anything above this line that is 0 is good, and anything that is below 0 is not as desired. So we can see that some countries might have experienced a slower growth in new patients, but overall the evidence suggests that most programs did well to maintain essential HIV services despite the challenges. And this was done through modification of services, including expanding multi-month drug supply, delivering drugs to patients in their homes, expanding the use of HIV self-test. And how does this translate in terms of the third 90, which looks specifically at viral suppression for our patients, and why is this important? So viral suppression is a very important indicator, as not only does loss of suppression has an impact on the individual, it also has public health implications in terms of preventing transmission. And generally, how have we fared globally? In a CDC MMWR report on PEPFAR-supported countries, among patients on ART who received viral load testing, the percentage who are virologically suppressed remains stable at 91% during October 2019 to March 2020, and at 92% during April to June 2020. In the more developed countries, so in studies that was performed in Brooklyn, Northern Italy, as well as Rome, there was also no significant changes observed in the proportion of undetected HIV viral loads pre-COVID as well as in 2020. But this experience is not the same in all centers globally. So for instance, in a publicly funded clinic in San Francisco, which provides care for approximately 2,400 patients, out of which 1/3 actually experience homelessness and unstable housing, the odds of viral non-suppression were actually 31% higher during shelter-in-place ordinances, and this was the equivalent of the circuit breaker that we have in Singapore. But when they looked at a subset of a patient, of 85 patients in the same clinic, was enrolled to this service called Pop-Up, which provides a low barrier and multi-component care specifically for homeless patients, the viral suppression actually remained similar during the pandemic itself. But just to take note that this percentage was actually much lower than the desired, so 48% pre-COVID and 47% during shelter-in-place ordinances. The interventions that they had at Pop-Up that was different from the clinic in general was that patients were able to drop in for visits without needing to make an appointment. There was on-site medication pickup, and patient outreach was conducted by phone or physically by a care navigator. So this seems to be in contrast to the remote services that were implemented during COVID itself. And I think what this really suggests is that when looking at different populations, remote services itself may not be sufficient to maintain the continuum of care for our patient. And we really need to look at our population characteristics to determine what measures to be put in place. So we'll just take a look at how HIV provision is like in Singapore. So mainly, as Sophia has mentioned, there are 4 main public hospitals in Singapore which provides HIV care. NCID is the biggest center with about 5,000 patients on follow-up. NUH and SGH each has about 600 patients, and Changi General Hospital has about 200 patients. So there's also a smaller number of patients being seen in other public healthcare institutions as well as in the private sector. And just to summarize the main adaptation to our clinical service made locally during COVID. So in accordance to the DHHS guidance that was released in March 2020, which recommends that telehealth services replace face-to-face encounters for non-urgent care, and that patients with suppressed viral load should have their routine in-person visits postponed to the extent possible. We actually converted outpatient HIV consults to teleconsults. We assured the continuation of ART through home delivery services. And in addition, as has been mentioned, something rather unique to our local setting is that a small but sizable proportion of our patients also obtain their medications from other countries and external sources due to cost issues. Some of our patients actually travel to Thailand to purchase medications, for instance, from the Thai Red Cross previously. And hence, with this travel restriction, this group of patients were particularly affected. So we ensured that there was a point of contact in each hospital that was readily available so that patients can seek help and get an alternative source of ART supply as necessary. So we conducted an audit to determine if these changes had any impact on our patient. The primary objective was to evaluate if the changes instituted in response to the COVID-19 pandemic had an impact on the viral suppression rates of HIV patients in 2020 compared to 2019. We also wanted to determine the duration between viral load tests that was performed in 2020 compared to 2019, to compare the volume of viral load tests in these 2 years, as well as the number of viral load tests that a patient had received. So we looked at the observational clinical cohort of HIV patients from NCID as well as SGH, patients who had first clinical contact from the year 2006 and had a viral load test performed in 2019 and 2020 were included. And we define virological suppression as a viral load of less than 50 copies per mil. So with that, we had 13,622 viral load test records on 3,873 patients in both centers. We excluded the tests that were performed on patients who are not on ART, the tests that were performed on patients before the initiation of ART, as well as those performed on patients who are on ART for less than 6 months. So with that, we had 12,698 tests on 3,683 patients for analysis. They were mainly males. They took out about 92.1%, and there were 7.9% of the population was female. So 6,396 tests were performed in 2019, and 6,302 tests were performed in 2020. So the volume of tests that was performed in these 2 years were largely similar. So we take a further look at the characteristics of this test performed. So as a breakdown, in 2019, 5,702 tests were performed in the NCID patients, and 694 tests were performed in the 422 patients in SGH. In 2020, 5,659 tests were performed in 3,082 patients in NCID, and 643 tests were performed in 413 patients in SGH. The mean duration from the time ART has been started to the test performed date was 77.1 months in 2019 and 85.8 months in 2020. And the interval between the tests that a patient had was a mean of 5.4 months in 2019. This increased slightly to 6.5 months in 2020, and the difference is actually statistically significant. When we looked at the proportions of all tests performed and the percentage of them that were less than 50 copies, this was 90.8% in 2019 and 91.4% in 2020. We also compared month on month the volume of tests done in 2019 compared to 2020. And we can see from the graph here that there is a drop in volume of tests that was performed in January to April, with a subsequent significant rebound in June. And I think this actually reflects the COVID situation in Singapore and the measures that have been put in place. So in January to March, even though there weren't that many COVID cases, there was a lot of uncertainty as well as fear for patients to actually come to the hospital for their tests to be done. And understandably, many of appointments as well as tests were actually postponed to a later date, especially for our stable patients. Singapore experienced a huge wave of infection in April, and our circuit breaker actually kicked in on the 7th of April. And as the cases gradually settled, the circuit breaker was lifted in June, where Singapore entered the phase 1 and subsequently the phase 2 of reopening. So this will probably explain the rebound of the number of tests we have that was performed in June itself, as patients probably felt that it was safer at that point in time to visit the healthcare center and had their regular tests performed. We also looked at the number of tests a patient received a year. The results is broken down into the 2 centers as it is quite different. So we can see that in NCID, most of the patients before COVID as well as currently actually has 2 tests done a year. and there was actually a drop in percentage of 7% in 2020 compared to 2019. And this group of patients had one test done a year instead, as can be seen from the corresponding increase of 7% of the patients who had one test done in 2020. In SGH itself, actually, it seems that the majority of the patient had one test performed in both 2019 and 2020. So there was no real difference in the number of tests performed in the patient in the 2 years. So for patients with tests that in both years, a smaller proportion of them actually had multiple tests done in 2020 compared to 2019. This was 74% versus that of 67%. So we then looked at the percentage of patients who were virologically suppressed, and we defined this as, or rather we looked at this at two different criteria. So firstly, the patients were considered to be virologically suppressed if their latest viral load was less than 50 copies. And we also had a stricter criteria that looked at all viral load tests done within the year, which has to be less than 50 copies. So in NCID, we can see that in 2019, 93.6% of the patient had a latest viral load that was less than 50 copies, and 88.2% had all their viral load tests that was less than 50 copies. In 2020, this was 94% for the former and 89.3% for the later. And we can see that for this small difference, it was the 95% confidence interval actually crosses 0. Similar results were seen in SGH as well. So what we can conclude is that there was actually no significant difference in overall viral suppression rate between 2020 as well as 2019. We then looked at the subset of patients who had test records in both 2019 and 2020 and compared them to the test they had in the previous year. So in this group of patients from NCID, 89% of this in 2019 and 91% were virologically suppressed. In SGH, 85% of patients in 2019 and 87.6% of patients in 2020 were virologically suppressed. And among patients who were virologically suppressed in 2019, 85% of patients in NCID and 93% of patients in SGH remain virologically suppressed with no bleeps. And in patients whose latest viral load was less than 50 copies in 2019, 6% of patients in NCID and 7.5% of patients in SGH had at least one viral load that was more than 50 copies, and this includes patients who had a viral bleed. When the cutoff was extended to 200 copies, 4.3% of patients in NCID and 2.9% of patients in SGH had at least one viral load that was more than 200 copies. So I think the main limitation in the way we've analyzed our data is that while it appeared that a certain percentage of patients have lost their viral suppression in 2020 compared to 2019, a subset of them actually had a single isolated bleed during the pandemic. And the reasons for this is likely to be independent of the pandemic itself. It would probably have been a more accurate reflection if we were to look at patients who had persistently positive viral load in 2020 compared to a negative one in 2019. But what we do know from the data we have is that this percentage would definitely be less than 5% in both centers. So to conclude, despite concerns that COVID-19 might worsen outcomes, there was actually no significant difference in the overall viral suppression rates that was observed in 2020 compared to 2019. The steady viral suppression, despite the extended duration between the viral load tests as well as a decreased number of tests performed in patients, suggests that the strategies employed, including telemedicine and medication delivery, were largely successful. And beyond the pandemic, these services can be an alternative to consider for stable patients as a supplement to inpatient consults. So I've come to the end of my presentation, and I would like to thank the NCID Clinical HIV Program as well as SGH Clinical HIV Program for the data they have provided for this presentation. Thank you.
Thank you, Dr. Tay, for your brilliant talk and smashing the third 90 in this COVID pandemic. Our next speaker is Dr. Darush Ozilsner. He's an infectious disease consultant in NUH. He received his medical degree and PhD from the University of Amsterdam in Netherlands. He's been working in the field of HIV for more than a decade with special interest in PrEP, treatment and prevention, and viral hepatitis co-infection. Dr. Ozilsner joined the Division of Infectious Disease at NUH in 2008. He's one of the co-founders and presently clinical director of the NUH HIV Program and the founder of NUH HIV PrEP Clinic. Dr. Ozilsner also served as the head of Division of Advanced Internal Medicine in NUH and the Vice Chairman Medical Board for Education of the Alexandra Hospital. He's going to speak to us about the elusive fourth 90, living well with HIV in the COVID-19. Thank you. Dr. Darush, please.
Thank you very much for this introduction. Indeed, elusive fourth 90. Very well put. Let me just share the slides. Hold on. Okay, I hope you can see it. If not, please let me know. Okay, so the fourth 90 goal, this is what I will be talking about in the next 20 to 30 minutes. Very quickly, here are my disclosures. And my presentation will cover the definition of the fourth 90, the components of the fourth 90 as proposed initially when the fourth 90 was defined. I'll talk a little bit about skepticism of the fourth 90, and then I will close off with the fourth 90 in Singapore and also some more information on the COVID-19 pandemic and the fourth 90 and the HIV services. I'm afraid that with this presentation, I'll raise more questions than be able to provide answers. And indeed, this is a very elusive topic. And it's a very interesting topic because we've been using this fourth 90 term quite a lot. I hear it all over, all around me. But when you come and when you sit down and think about it, what it really is and how to achieve it, it becomes really much more complicated. One of the things that we are probably most proud of as people taking care of people living with HIV is that with the current treatment, of course, our patients can look forward to life that is as long as anybody else. And I'm sure most of us share that with our patients on the first visit when they come and see us and are quite devastated by the diagnosis. So we know that people with HIV indeed live long lives, but not necessarily live lives well. And this is what the fourth 90 is really about. So what is it exactly, the fourth 90? The term fourth 90 was introduced by Lazarus in 2016 in this article in BMC Medicine entitled "Beyond Viral Suppression of HIV, the New Quality of Life Frontier." And the way that Jeffrey Lazarus defined it was that 90% of those who are virally suppressed should have good health-related quality of life. Sounds good, sounds logical, and I'm sure everybody will agree with this. However, in the same article, Lazarus also asked himself, what is it really, this good health-related quality of life? How do you define it? And how do you measure the progress towards this 90% of virologically suppressed people who have good health-related quality of life? And unfortunately, these questions since 2016 still remain largely unanswered. We see from time to time this new treatment cascade. We are all very much familiar, of course, with the 3 boxes of the 90. And then, of course, the last 90 is the good health-related quality of life. The original article proposed actually 2 domains of the health-related quality of life. One is comorbidities, and the other one is self-perceived quality of life. In terms of comorbidities, it is quite straightforward. Definitely for those who who have been treating HIV for a decade or decades, there has been very clear shift from focusing on survival of our patients and prevention of severe opportunistic infections to shifting the focus to basically good life and healthy life. So we started being confronting more and more with chronic conditions because obviously our patients live longer. Let me move to the next slide. And of course, as they live longer, it's logical that they are more prone to develop chronic conditions just like anybody else. And this is in the context of populations which are largely heading for acceleration to older age. We see that definitely in the developed countries, including Singapore. However, some chronic conditions are more prevalent in people living with HIV, irrespective of their age, irrespective of the fact that they just live longer or as long as general population. For instance, kidney disease, hypertension, diabetes. These are conditions that we find in people living with HIV at a higher incidence. We have very clear indications that people living with HIV experience premature aging. Definitely those who are not biologically suppressed, but even we see that possibly even in those who are biologically suppressed. There's also evidence for premature cardiovascular disease, again, even in people living with HIV who have been biologically suppressed and immunoreconstituted for years. And we think that this is driven by inflammation that is not fully inhibited by or stopped by antiretrovirals, even with full biologic suppression. So many factors that contribute to the fact that that our patients experience many chronic conditions, and initially we were not really focused on addressing that. But there is more to this. Not only do our patients experience more chronic conditions, but there are barriers for them to access care for these conditions. You would think, what's the big deal, right? I mean, obviously, someone may not want to be linked to HIV care because of the stigma, but why should that prevent people accessing diabetes care or hypertension care or other health services? And yet, we know that there is stigma among healthcare providers, and people living with HIV really are worried about disclosing their status to the healthcare providers, and sometimes they don't. I'm sure that many of my fellow HIV care providers know situations when our patients go to the GP, let's say for flu or for what they perceive as gastroenteritis, and they don't even tell the GP that they live with HIV. So that really poses a barrier to proper care for chronic conditions. And we still see many healthcare providers not comfortable treating people living with HIV. Let me show you this slide. This is a slide from a paper from 2017 from the United States, which looked at comorbidities in people living with HIV between 2003 and 2013. So it compared people with HIV experiencing these comorbidities over the 10 years, and it started following them up roughly 6 years after introduction of highly antiretroviral therapy in 1996. And you can see here that across the board, there has been an increase in prevalence of these conditions. Really, what stands out here is, of course, hypertension, hyperlipidemia, but also diabetes, cardiovascular disease, renal impairment, and also obesity and overweight. That may not apply to Singaporean patients that much, since this paper was done was published in the United States, and of course the obesity patterns are different there than in Asia. So what about self-perceived quality of life, which is proposed to be the second component of the health-related quality of life? Comorbidities seems quite straightforward. It's a matter. It seems to be a matter of diagnosing them, being aware of them, linking patients to proper care, and making sure that these comorbidities are taken care of. Of course, easier said than done, but is quite straightforward compared to this second component of the fortnighty, self-perceived quality of life. This is a study published also in 2006, paper published in 2016 by the same author, Jeffrey Lazarus, which showed that even those people living with HIV who are fully biologically suppressed report higher levels of symptoms such as fatigue, energy loss, insomnia, depression, sexual dysfunction, changes in body appearance. And these are, of course, symptoms that are not always represent a factual chronic condition or comorbidity, but these are symptoms that really bother a lot of our patients. And some of them are not reported by patients easily. It's probably easier to pick them up during research and trials, but in real life in a clinic, these self-perceived aspects of quality of life are often go unreported for several reasons. Some patients feel that they should already feel lucky to be alive and to have a good life expectancy, and they feel incorrectly, they feel that they should be able to deal with this because this is minor compared to the death sentence that HIV used to be associated with before we had a successful treatment. Our consultations, of course, are always limited by time. We as healthcare providers often like to focus on viral suppression, checking the labs, sharing with patients lab results, maybe doing some vaccinations. But these are aspects of well-being that often go underdiagnosed and are not often discussed with our patients. In 2014, in this Lancet paper, they looked at 10,000 individuals in the United Kingdom. This was a retrospective study where they compared 3,000 people living with HIV with 7,000 members of the general public. And they have shown that there was significantly lower health-related quality of life scores when they were measured in people living with HIV. So when you measure these scores, you find that they are lower in PL-HIVs compared to general population. But the question is, how often do we measure it? How often do we discuss it in our clinics? What's important is that vast majority of of these 3,000 PL-HIVs in the study were biologically suppressed. So in spite of biologic suppression, they reported lower quality of life scores. Okay, so the fortnighty, as I wrote here in this slide, it's a catchy name. We love the 90 goals. We've been talking about the Millennium 90 goals for many years now. We are by far less as a world community, we are by far less successful in achieving them, but we love talking about them. And indeed, very quickly, this fortnighty became something that has been used by a lot of us. However, some feel some skepticism for the fortnighty, the way that it has been defined, and also the way that we approach it. One of the points of criticism is that we still have a situation in the world where in some resource-limited settings, only a small fraction of those people who live with HIV have actually access to antiretroviral treatment. So the question is, should we really bother about the need of already biologically suppressed patients in the rich countries, while in our own region, Asia Pacific, in 2020, only 61% of people living with HIV were biologically suppressed, according to this UNAIDS report. I think most of us cannot help noticing how this echoes what we hear nowadays also about the access to COVID vaccinations across the world, and the big divide between the the rich world and the resource-limited world, and how we approach health and care in these settings. So this is definitely a point that that is important. I don't think that this should prevent us from trying to define and work towards the 490 goals in countries where it is possible. But it should actually let us focus even more and make our global efforts even stronger to try to really get more people virologically suppressed. And another point of criticism, which I very strongly agree with, is this cascade as it has been presented by Lazarus in his original paper in 2016, where you see that 90% of the diagnosed people living with HIV should be diagnosed, 90% of those should be on treatment, 90% of those should be virally suppressed, and then 90% of those who are virally suppressed should have good health-related quality of life. So this is not very inclusive, right? Why should only those who are virally suppressed? Why should we be focusing only on those who are virally suppressed in terms of providing good health-related quality of life? What about those who are on treatment but who have not achieved viral suppression? Or what about those who are not on treatment but live with HIV, diagnosed or undiagnosed? So I think that this, as shared by others, is probably a more appropriate way of describing the fourth 90 and putting it in the context of the previous three 90s. So what is exactly this target of the fourth 90 and how do we operationalize it? The definition is a bit vague, right? Good health-related quality of life, but how do we measure it? In terms of comorbidities component, it may be relatively straightforward. We may need to develop some metrics in our clinic or in our health systems where we make sure that the comorbidities that we often see in people living with HIV are screened for, diagnosed, and then the patients are linked to treatment in the appropriate way. How to link them to treatment and who should do this treatment is a big question, is a serious question, definitely unanswered. In terms of the second component of the fourth 90, the self-perceived quality of life, that is by far more tricky. How do we define that self-perceived quality of life, and how do we find out about the experience of our patients in terms of self-perceived quality of life, particularly in clinics that have short consultation times, where doctors are overloaded, when we have another pandemic that we've been dealing with for now basically 2 years. That is really much more tricky to address. One way of addressing it possibly is looking at patient-reported outcomes, so-called PROs. And there is some evidence that this could help us define better the particular self-perceived quality of life. The PRO is basically any report of the status of a patient's health condition that comes directly from the patient without interpretation by a clinician or anyone else. It measures patients' perspective of their own health and not just the objective clinical findings by the clinician. And very often it cannot be directly observed by clinicians. And PROs help also understand person's health in a more multidimensional and holistic manner than just a pure clinical approach allows. Again, sounds good, but to apply it and to test its validity is much more difficult. We need still more research to show the utility of PROs. So far as there has been no link shown between improvement in PROs and improvement in health. We basically need to develop our own PROs, because PROs can be very culturally very sensitive. So whatever PROs are developed in Sweden, Germany, or the United States may not apply to China, Laos, or Singapore, or Australia. And when developing PROs, what is certain is that, and that cannot be stressed more strongly, is that of course we need patient involvement in the development of these PROs, because it is about very often hidden issues and hidden complaints that otherwise we do not that we are not able to pick up as clinicians, as doctors, nurses, or social workers, or other specialists. And how can we change our health systems to promote wellness and not just survival? This is the next step. So once we define the 490, once we define what it really means, how can we transform our health systems to shift the focus from purely biologic suppression and going for better survival to better quality of life? Safrid Harmon in 2019 proposed these 4 key strategies for health systems to employ in order to make the transformation and reorientate healthcare systems. The first strategy is health service integration, in which they postulate to identify within the health system priority areas for health service integration with HIV health services, and also to conduct very rigorous research, which will help us make a future decision about how to organize our services for people living with HIV in the context of good quality of health-related quality of life. The second key strategy is HIV-related discrimination in healthcare settings. And this is quite interesting because they really go into more granular proposals. We all talk about the stigma and discrimination against people living with HIV. We know that particularly that stigma and discrimination among healthcare providers can be very devastating to our patients and to their health. But except for maybe slapping our colleagues' wrists from time to time and trying to educate them, we don't really do much in a very formal and structured way. And what this strategy suggests and proposes is to actually monitor experiences of discrimination against people living with HIV in healthcare settings, and to implement evidence-based and, what's important, multi-stakeholder interventions to eliminate discrimination in healthcare settings. And it also postulates to incorporate indicators to measure progress against discrimination in healthcare settings at the national level or at the healthcare institution level. And this can be really impactful. We have research, some research about the discrimination among healthcare providers, but we should really try to use this more granular approach to improving the situation for our patients. The third key strategy is creating indicators to monitor progress towards the new goal. And the fourth strategy is engagement of the civil society in helping civil society to also reorientate and transition to address the broader HIV care agenda beyond biologic suppression and beyond survival. Okay, so the 490 in Singapore, where do we stand and what is the situation here? As most of you know, we have, of course, excellent healthcare system with excellent access to antiretroviral agents, particularly after introduction of subsidies, which Sophia mentioned in her talk earlier. We have high levels of biologic suppression among our patients, as Ian mentioned just a few minutes ago. Even in the time of COVID, the biologic suppression was excellent in Singapore, and we have long life expectancy for our patients. However, at the same time, Singapore has a high prevalence of chronic conditions among general population, which is driven, of course, by aging population. We have particularly high levels or high incidence of diabetes. And at the same time, our healthcare system is very subspecialized. And it does not really encourage HIV doctors to function as general internists. We all have received general internist training of some kind. But once we do our infectious diseases training, and at one point focus mainly or partially on HIV, that general internist experience, of course, is a little bit eliminated and disappears somewhat, and we are less comfortable treating chronic conditions at an internist level. At the same time, we still have prevalent stigma of HIV among healthcare workers and beyond in Singapore, which poses, of course, a barrier to an obstacle to introduction and fulfillment of the 4/19. In terms of the stigma of HIV among healthcare workers, this is an old paper. Fortunately, it's from 21 years ago, so the data is quite old, but it does show 2 decades ago, really very prevalent stigma against people living with HIV. Hopefully, this has changed significantly for the better. I'm not sure, I could not find any recent studies. I know that there was a study done in NCID, but I don't think it was published yet. Definitely, we think the stigma is better, but we are not there yet. I will just let you read this slide. This is my own experience that my own patient shared with me only within last 12 months. And I'm sure that many other healthcare providers also have similar reports from their patients in regard to the stigma that they experience in healthcare settings. And in fact, yesterday during my clinic, I had another patient who also complained about the doctor when he was admitted for an infected wound, a doctor who insisted on using double gloves to inspect the wound. And even when my patient, who was very vocal, said something, the doctor was actually very defensive and insisted on using double gloves. So stigma among healthcare providers still exists, and definitely is a barrier to achieving the 4/19. So how can we aim for the 4/19 Singapore? How do we do it? Particularly, how do we, even with the simple things as comorbidities, all right? There are more questions than answers. Should the HIV doctor do it all? Should there be a resident general internist in clinic, a psychiatrist and a geriatrician on site who can be consulted and who can see the patients together with us? That is, of course, very manpower consuming in the system, which is, of course, struggles with manpower, just like anywhere else in healthcare. Should an HIV clinic collaborate closely with a particular subspecialist who has interest in HIV and exhibits no discrimination towards people living with HIV? So these are the possibilities that there are to address comorbidities, not even the component of the self-perceived quality of life. And it would be great to hear from my colleagues from other institutions how, or from even better from people living with HIV who may be, who I'm sure logged into this Congress, to hear what they think, how we should do it. I think that there will be very interesting discussion after this talk if we have time for it. The last part of my talk, very quickly, because there is some overlap with what previous speakers said about the impact of the COVID-19. In our experience in NUH and also beyond NUH, there's been definitely impact on PrEP and sexual health services because of lockdown, because of shifts of manpower to COVID-19 services, limited slots in sexual health clinics. Sexual health services are not considered essential, and also patients afraid to visit healthcare facilities because they were afraid to catch COVID, particularly before introduction of vaccinations. At the same time, there was the silver lining, as Sophia pointed out, is possible with the introduction of telemedicine, and definitely in the PrEP services, we have seen introduction of telemedicine. And in fact, in other countries such as Thailand, there's been a quite wide introduction of tele-PrEP even before COVID. In our own clinic, the telemedicine start was slow. In 2020, we had only 23 teleconsultations, so it is very, very slow, but it really picked up in 2021 until from January to October, we see really massive increase in teleconsultations, which are of course ideal for stable patients who do not need to come to hospital. However, the question remains, We know that the COVID-19 from Ian that does not seem to influence virologic suppression in Singapore. But what about regular STI screening? What about regular blood pressure screening? What about non-COVID-19 vaccinations? If we do telemedicine, of course, we can always say, oh, this patient can have teleconsultation, and then he or she just comes in for the screening or for the flu jab. But there may be, and we do not have the data, but it may be patients just may not bother to come just for the vaccination after the teleconsultation. This is very raw and recent data from our clinic in NUH. We didn't have a chance to analyze it more thoroughly yet. But without even statistical analysis, you can see here that in 2020, the blood pressure measurements have really drastically dropped in our clinic among people living with HIV. So that obviously can have an impact on diagnosing hypertension, which we know is more prevalent among people living with HIV, and also on the control of hypertension in those who are already on medication for high blood pressures. We saw not much drop in influenza vaccinations, but some consistent drop in gonorrhea and chlamydia PCR tests. Again, no analysis done whether it's statistical or not. But I think that the blood pressure measurements are really quite clear here that they have decreased, and that is worrying in the long run. Again, I think both Sophia and definitely Ian mentioned people living with HIV who have the group of people living with HIV, Singaporeans who have sought HIV care overseas, particularly in Thailand. And now, because of the border restrictions, we're not able to access their antiretrovirals. This is the numbers from our clinic in NUH, and you can see that the number of our PL-HIVs who were not getting ARVs from our pharmacy really clearly dropped over the years since 2019. So from 149 to 114, which is basically a 30% drop, and then further to 98 from January to October this year. Just to finish, take-home messages from this talk. So although ART has led to virtually normal lifespan among our patients, HIV continues to affect morbidity. Intuitively, we all agree that HIV care needs to extend beyond viral suppression to improve health, and not just health length of life, but it remains to be determined how we define the 490 target and how we reorganize our health systems to reach it. The persisting effect of HIV on health-related quality of life, despite virologic suppression, could be avoided by preventing HIV infection in the first place. So, if we get our prevention right, with PrEP, with treatment as prevention, with encouraging patients to get individuals to get tested, then we will not be even talking about the 490 for people living with HIV. And then the true effect of the COVID-19 pandemic on local HIV and sexual health services is yet to be clearly determined. Thank you very much for your attention.
Thank you, Darush, for the enlightening talk. I particularly love the bit where you say that the 490 is actually epicascadic and it can act on the earlier 90s. Yeah, and so without further ado, we now launch into the Q&A section of this symposium. So can we invite all the panelists back? Yes, hello, Xiaoyi. Let's see. So, so the first few questions have already come in. Actually, one of the earlier questions is about HIV testing. It is from Rainer. He asked about immigration restrictions, whether if there's any scientific or evidence or modeling study that says that such HIV differentiated immigration restrictions will impact on HIV incidence and financial implications on Singapore. So what can we say about that? Maybe we can ask directly to Xiaoyi, and later everybody can join in.
Yeah, sure. Right. Thank you. I think Reina directed the question at all the panelists, but I'll take a stab at it first. So I think one thing the National HIV Program agree for sure is that these laws are antiquated. They came at a time of when the HIV pandemic was raging across the world, and there's very poor understanding of the disease, and there's certainly no effective treatment being available. And at that time, it also happened at the same time where Singapore ourselves also had a quite increasing number of newly diagnosed HIV infections, and therefore the response to that at that time was just to do a ban on foreigners who have HIV infection, the idea being that they want to somehow reduce spread within the country, and also perhaps a bit of concerns with regards to the financial implication on the country's healthcare system as well. So I think across the world, there are several countries which have since changed and lifted this ban as well, because clearly we know that HIV is not transmitted through casual contact, it's through sexual intercourse. Therefore, unlike other diseases, let's say even COVID, for instance, it's a bit harder to spread. There are also more effective treatment now, and certainly individuals who are well controlled cannot pass the disease. In terms of whether there are studies that shows the financial impact on this restriction on the country itself, I am not sure about this. I think my other panelists can jump in. I know there's certainly studies that show the financial impact on the individual itself from this restriction. And of course, there are obviously a significant financial kind of like impact on people living with HIV who have immigration, who are restricted to enter countries, whether they are immigrants or whether they are higher collar workers coming in. But I think regardless of regardless of the financial impact on the country, this is still a law that in place actually just discrimination against people living with HIV. It should be reviewed, I think, and it's something that we are certainly looking at, and hopefully, as with most things with policy change, all this thing takes time, but hopefully in time we will be able to change this law. So I think I'll pass on to the rest of my panel as well.
Sure, I can jump in on this one. And I think we've had a couple of related questions that pertain to U equals U and where we are now and how that impacts stigma, of course, to the individual, but also societal change and policy change. And that's the idea, right? As the overwhelmingly science has shown that U equals U is real. The strength behind it is undeniable in terms of the strength of the evidence. It really is time to incorporate it into decision making, both for individuals, public health campaigns, as well as policy change. Certainly from the NHIVP side, that's something that we're working quite rigorously and religiously on, I guess I'd say. And I know we have the support of many of our partners on this. Thanks.
Yeah, I'm gonna jump in, and I know I wasn't part of the this panel, but I think I just want to echo, what Sophia said. Just as an additional point is that we have been making progress. I think the fact that the destigmatization campaign that has come out this year, which I alluded to in my address in the first session, is already in a way unimaginable, maybe even 5 years ago. And this reflects not only change at policymaker and practitioner level, but also change at, I think, society and community level. And I think the tempo and the rhythm with which communities and societies change may be different across different settings. I think what we are doing is, perhaps progressing along this this timeline, and hopefully we'll have things to report back that will put Singapore on a similar trajectory as the rest of the world when it comes to policies, laws, regulations, and other societal mores. So thanks very much.
Okay, thank you for working so hard on this very difficult problem. So there's another question by Dr. Jeffrey Cutter. Actually, he asked if HIV testing can be done without direct consent, if clinically indicated, meaning, can we just do it like a full blood count or renal panel? Can we destigmatize it until HIV testing is just a routine test without direct consent? What do you think? How far are we from that?
So I think I'll take this one. In an ideal situation, I think that is definitely what we want to achieve. And I think that is also the reason why we came up with the testing recommendation. We do acknowledge that there is a lot of hesitancy, I think, sometimes in actually administering HIV tests, because also the stigma that's associated with the test. That being said, I think also Dr. Jeffrey is kind of asking, because for Singapore, at least for patients who are diagnosed with TB, routinely we actually do the HIV screen. I think if we have to do counseling for every one of the patients who are diagnosed with TB, it can be difficult and fairly labor intensive as well. So I think at least in my own practice, usually I do just mention to the patient that a HIV screen will be done, and like briefly explain why, because of its of the increase, because HIV increased the risk of TB, and therefore we do the HIV screen. For individuals whom I feel, you feel are definitely at higher risk of HIV, for instance, they have other besides TB, they present with other AIDS-defining illness. For instance, they have oral thrush or candidiasis. Then I think there is some value in actually giving a more detailed kind of pre-test counseling, because the likelihood of the test turning positive is higher, and therefore it's a good practice, I think, to counsel this individual. I agree. There are certain individuals who it's just TB, they are close contact of a person with TB. They don't really have risk for HIV, and there could be unnecessary deterrent to actually doing the HIV test if you do too much unnecessary pre-test counseling. So can't say there's a one-size-fits-all kind of question. It really depends on the individual as well and the patient. Yeah. Okay. I see Dr. Darush has raised his hand as well.
Yes, just very quickly. I can see where we are coming from, but I would say that even for a patient who has TB and for whom you would like to do an HIV test as part of the routine testing, which of course should be done, and we think, okay, this patient is not particularly at risk. The thing is that we don't know, right? Because do we really think that the patient who comes to us for pulmonary or spine TB will immediately disclose that they are at risk for HIV? I think not. And we by no means can we ever compare FBCs to an HIV test. If we can compare FBC to HIV test, then our work and Sophia's and Chenxiong's and your work is done in terms of stigma and discrimination. No more work needs to be done,
I'm going to throw the word differentiated out there again, because we've been using it a lot. So in the same way that we talk about differentiated care services, differentiated testing services makes sense as well. So whom to counsel and how much above the minimum that's recommended, then the guidelines are there for individualized differentiated approaches. How did we do, Jeshen? Is that, did we get to the?
I think that sort of answers it, but I don't think in this kind of difficult questions there's a one size fit all. It really depends on the individual setting and the patient and the direct individual relation between that doctor and that patient.
I think we did make it clear there's no separate consent form, which is something that's brought up, and you have sometimes people scrambling to find this. Like, where's the consent form? There is no consent form. So it's the principle is individualized decision and informed decision making. That's the standard, and it can be opt-out when implemented in a programmatic sense, like is done on inpatient admissions to hospitals. But certainly when there's indications for testing that are very specific to that individual, then so should the discussion around HIV testing be.
All right. There is this certain view from an anonymous attendee who thinks who says that in an ideal situation that should be what we should do, but there's the risk that we'll inevitably turn away people from seeking treatment if we are testing them for HIV without their consent. I think that's of course a valid concern. Do you think our local population are sufficiently destigmatized that we can just test them like that currently?
No.
Okay.
I think that's good. We're not there yet. I mean,
we're not there yet.
We're not there yet. I don't think we're there yet. In any case, by the recommendation, like I've said earlier, individuals who you're administering the HIV screening test on, they should know that this test is being done on them. This should not be done without their consent.
Agreed, exactly. Okay, there's a very good question by, I think one of the anonymous attendee, saying that there is still some, I mean, we already know that from Dr. Daru's talk that there are more comorbidities in a PL-HIV as compared to a normal population. He says that GPs and general primary service at large still feel a little bit inadequate, either technically or just still not very comfortable with treating comorbidities in this population of patients. So I'm just wondering, is there any programmatic or formalized approach to engage our primary care partners to either upstage, to increase their competency or to share our experiences such that we can push out our primary care in PL-HIV to our primary care clinics and OPS?
I think that's one of these million-dollar questions, right? How do you approach comorbidities in PL-HIVs?
Yeah.
Do you want to do it all on your own? Do you want another specialist to do it? Do you want a GP to do it? It's a difficult question. There are countries where stable PL-HIVs are treated by their family physicians. Definitely in Australia, I believe also in the UK, definitely in the Netherlands, the stable asymptomatic PL-HIVs will not be under treatment of HIV center, although HIV center could be involved for any issues. I don't think that there are any projects at this moment to involve GPs closely in a programmatic way in treatment of comorbidities in people living with HIV, and I'm not surprised that there may be some apprehension from GPs to do it, because there are differences, right? So even if someone is virologically suppressed and healthy, treatment of an approach to, let's say, a cardiovascular disease or even diabetes may be slightly different than for general population. So without proper training and maybe selecting those who would like to provide such care, I don't think we can even think about it at this moment. But please, maybe others have other ideas or are aware of other initiatives ongoing.
Yeah, hi, I'm Matthias. Just sharing some experience as I've previously worked in the polyclinics before. We do have patients with HIV coming for chronic care, the routine, periodic, maybe 3 monthly to 6 monthly kind of follow-ups. And generally, we will be able to manage the chronic care quite all right. Yeah, so but I think it's specifically for just the HIV component, the polyclinics probably, or the GP clinics probably may not be able to run all the various tests that are needed for the routine HIV follow-up. So, and I think we are quite fortunate that our numbers are not too big. So our specialist clinics, the 4 hospitals with the programs are able to handle right now.
Yeah, I think the setting is, as we talked a little bit earlier in terms of the lay of the land for treatment services in Singapore, is a blend of 90% or more being cared for at the 4 public healthcare institutions, which is primarily specialist-based care, and then about 10% or less across private ID specialists and some GPs who clearly have the interest and give themselves the capability to care for patients, primarily who are on first-line regimens. It can be challenging, yeah, as Matthias, you say, because in terms of what investigations are available and also comfort level across providers. There are certainly education and training programs that we hope more providers can avail themselves at with, like the Asia Pacific HIV practice course, the healthcare worker HIV education modules that are offered by the 4 clinical programs together to empower, I think, a lot of people who deal with the comorbidities and how to do that in a sensitive way, and also a way that doesn't jeopardize the patient privacy, confidentiality, but also very practical things like drug-drug interactions with ART, etc.
Okay, thank you. I actually was looking at the list of chronic comorbidities and some of these guidelines in people living HIV, and I thought that the number of things you have to look out for in primary care when it comes to cancer screening, destigmatization, it's not 2 TCUs a year. It's something like 5 or 6. So I didn't think that I would even be able to cope with that doubling of the burden of the clinic burden. So we're really glad that our primary care partners are helping us with this. So actually, I have one question. Maybe we can ask this to Sophia or Ian. Actually, with this pandemic coming on, and most of your teleconsults have gone up in frequency, double, triple, and that's become the primary mode of delivering HIV care. After this, do you think it's still going to move that way, and we'll still get people transiting more to teleconsult, or do you think the HIV population is still wanting that physical connection?
Well, I will take that. So I guess there's actually two very specific group of patients that we see in our setting. So I think the younger population who is more IT savvy and more comfortable with the idea of teleconsults would be the population that we will target in future, even after the pandemic, for this to be something that we can continue in their care. But there is definitely a group of patients who are older, who are still not comfortable with teleconsult. Some of them actually feel that being able to come down for a clinical consult would address their concerns more adequately. Some of them feels that having a consult over the phone or over the virtual space is actually something that is not as confidential as coming to the clinic itself. And I think this group of patients, especially the older ones, will probably need a little bit of help if we do want to push out teleconsults to them. But I think in HIV care, again, is a lot of differentiated service delivery. And it is really not one size fits all and what really is best for our patients. Yeah.
100% agree with Ian. And I would add the other, as part of differentiated care, there's the patient or client selection, but also I would argue the client or patient provider relationship itself is important. So those, if I have a patient who I've been following for 5 years, 10 years, and you really know the ins and outs of how they present, how they put complaints to you, or what are the nuances of their care, it's much easier and safer to do it, even over the phone or over video consultation, than only relying on face-to-face. Whereas somebody where, even if they're young, tech savvy, but somehow you don't have that knowledge about the patient, to have faith in what comes, the things that you might miss, right, over the phone or over the video consultation is important as well. Yeah, thanks, Joshin.
Okay. All right. Thanks for the very comprehensive answer. A certain anonymous attendee also asked that he thinks or she thinks that the best and most impactful way of achieving the fourth 90 across all the 3 90s, apart from effective destigmatization, is to make ART affordable and accessible to not only rich countries, but also resource-limited countries. So I don't consider Singapore a resource-limited country, but we do have resource-limited individuals. So perhaps if we were to modify the question a bit, and this, the question is, this is obviously unachievable without big pharma, government-private collaboration. How far are we, or how near are we from this ideal big pharma, government-private collaboration in achieving the 490s in resource-limited countries, or in our case, individuals? What do you think? Maybe I direct this at the Rouge or maybe the director.
Yeah, when you talk about the resource-limited countries, of course, I'm assuming you mean sub-Saharan Africa, some countries in the Middle East. When you look at sub-Saharan Africa, there are countries where the general population does not have access to health, very often access to healthcare, simple healthcare such as detection and treatment of diabetes and hypertension, right? So I think it's very difficult to expect people living with HIV to get that kind of access. I think that that's just not possible, On the other hand, in Singapore, I think you are right that there are individuals who have more challenges in paying for ARVs, but to be honest, even definitely for Singaporean citizens, even if someone does not have MediSave, they often can get MediFund or MAF Plus. So even though living with HIV is definitely not free financially, and definitely there is a financial burden. I do not think that there is really a problem of access, financial barrier to access to ARVs for Singaporean citizens. And when I look at our clinic numbers, and please share if your experience is different, actually we do not see people in our clinic, Singaporeans, who are not on ARVs because they cannot afford it, you know. And yeah, so I think that the access is already there, and that is also reflected in our national numbers of the third 90. We have very good levels of biologic suppression as the third 90. So we actually, of course, we can do better always, but this is already quite. So the third 90 numbers in Singapore actually reflect very good access to treatment.
Okay.
Thanks, Terry. Jeshan, just one quick comment for me. The team has reminded me to share with everyone that a lot of the questions that come up in terms of primary care, the fourth 90, and comorbidities, we hope that we can address as the work group comes together to develop our first ever primary care recommendations for people living with HIV. So stay tuned. Thank you so much.
Okay, thank you for that very comprehensive answer. And then we have addressed all the big themes. I think no more questions are coming in. So thank you for your attention. And this has been a very wonderful segment. And thank you for all participating and esteemed speakers. Thank you.
Yeah, thank you, Dr. Loh, and all the speakers for the insightful discussions. We will now take a quick break for about 10 minutes. Please stretch a little and relax, and join us again at 11:35 for the next segment with our keynote speakers. Hi everyone, welcome back to the second segment of session 2. I hope everyone managed to get some snacks and stretch your legs a bit. Now let us welcome Dr. Wong Chen Siong, our Deputy Director of the National HIV Programme, to bring us through the next segment on keynote topics. Dr. Wong, over to you, please.
Thank you so much, Sally. Thanks everyone for coming back for the second half of the second day of the Singapore HIV Congress, where we are very, very privileged to have with us two keynote speakers, as Sophia introduced them earlier on from just up north. The first plenary speaker will be Dr. Rina Rajasurya, who is an associate professor at the Department of Medicine, University of Malaya, and is also an adjunct research fellow at the Peter Doherty Institute for Infection and Immunity in Melbourne, University, Australia. Rina graduated with her Bachelor of Pharmacy as well as a Master's in Clinical Pharmacy from University of Science Malaysia, and then obtained her PhD in Immunology at Monash University of Australia, focusing on immunogenetics and immune activation in HIV. She then returned to Malaysia to establish the core immunology research facility at the Faculty of Medicine, University of Malaya, which she currently leads. Dr. Rina Rajasurya also coordinates the translational research program in HIV immunology and aging at the Center of Excellence for Research in AIDS, or TIRIA, in University of Malaya. Her research focuses on understanding the immunopathogenesis of aging in people living with HIV, and that is the topic that we've asked her to come and speak to us today about, preparing for an aging HIV population. So, Rina, please. Thank you. Thank you so much, Rina. I think in your comprehensive overview, you've really given us a lot to think about. And we will have questions at the end of both plenaries. And on that note, it gives me great pleasure to introduce Professor Dr. Adiba Kamarul Zaman, who is a Professor of Medicine and Infectious Diseases at University of Malaya and an Adjunct Associate Professor at Yale University. She was Dean of the Faculty of Medicine, University of Malaya from 2011 to 2019. And of course, she's currently President of the International AIDS Society. She's got far too many achievements for us to sort of list through this morning, and I'm sure she would not want me to go through all of them. So it gives me great pleasure. It's a real privilege to introduce my friend, Professor Adiba, to give us a talk on HIV stigma in Asia. Professor, please.
Thank you so much, Chen Xiong and dear colleagues over in Singapore. I wish I was there with you. I'm dying to travel back to Singapore. So VTL and Omicron permitting, hope to see you in person very, very soon, and hope to host you in KL, all of you as well soon. So my presentation this morning is on HIV stigma in Asia. As many of you are aware, this is the Achilles heel of the HIV response, not just in Asia, but globally. We have all the tools, old and new, to prevent and to treat HIV, but in a sense have not been able to successfully scale, whether it's antiretroviral therapy or PrEP, and many other tools that we have at our disposal to bring an end to AIDS, partly and largely because of the existing stigma and discrimination in many shapes and forms that we experience daily. In fact, just as I was preparing to log on to present, an email came through of a colleague who's having trouble, a doctor who is living with HIV, who's having problem renewing his annual practicing certificate, although he's been cleared as fit to practice because of the bureaucracy and inherent, I think, problems with how people living with HIV is being viewed in many of our existing healthcare systems. So one of the culprits of stigma and discrimination, as was mentioned by Rina as well just then, is the healthcare system itself. So what I'm going to do this morning is to run through various aspects of stigma and share with you how I think in our region the prevalence and the level of stigma is still almost pre-antiretroviral levels. I think, as you can see here in this UNAIDS Global HIV Report from 2021, many countries in all parts of the world still report a large percentage of people having discriminatory attitudes. In our region, Tonga, the Philippines, Indonesia, Malaysia has not been surveyed here, but there's a whole range from just under 30% in Thailand to 90% in those surveyed in Tonga and 70% in the Philippines. So without a doubt, I think we still see high levels of stigma, and this was from previous years' Global HIV report published by the UNAIDS. The question was, would you buy vegetables from a shopkeeper living with HIV? And between 2014 and 2018, more than a third of those surveyed still answered that no, they wouldn't buy vegetables from the seller who's living with HIV. And as you can see here, the percentage of population who was surveyed. So it's pretty upsetting, and you think 40 years on the levels of stigma would dissipate, but not to be so. Here are some of the data on levels of stigma. That was the vegetable seller question. In 5 countries, more than 20% of people think that children living with HIV should not be allowed to go to school with other children. In Laos, 75% of MSM surveyed said they would avoid healthcare for fear of being stigmatized and discriminated against. In Thailand, where you think, it's much living with HIV is much more acceptable, still 8% of female sex workers and 6% of transgender reported avoiding healthcare, again, due to negative healthcare provider attitudes. And there was a Fijian study looking at stigma index, not just in Fiji, but surrounding neighboring islands as well. and 70% of respondents reported feelings of shame, guilt, self-blame, and low self-esteem in the previous 12 months due to their positive status, and 22% have felt suicidal. So it's, as I'll share with you later, you know, the impact and the outcomes of stigma are huge. Yeah. So in Malaysia, we've done some similar surveys, beginning with medical students, as well as doctors in training, as well as doctors as well, and looking at stigma indices and intentions to discriminate. These were the questions that were asked in this study, evaluating physicians' intention to discriminate, unwilling to work with people living with HIV, provide care, willing to do physical examination, willing to interact. And in summary, what we found was that the more senior the doctors were in service, the less you know, evidence of intention to discriminate, thankfully, and but also the intentions to discriminate was, you know, we used to think this what we all kind of, I guess, have experienced this, but even in this survey, it kind of showed that those in surgical services were express an intention to discriminate more than you and me, Cheng Siong, physicians, people like us. So it is not just anecdotal. It's not just what we think. When in this study that we did, it did show that unfortunately our surgical colleagues were more likely to discriminate, and it stems back to this fear of getting infected by patients as one of the bases for this stigma and discrimination. So this is hot off the press, so to speak, from Malaysia's National Health and Morbidity Survey conducted in 2020, but analyzed and released just earlier this week. And I think for the first time, there was a section on communicable diseases, HIV, hepatitis C, etc. And I've just plucked out the section on stigma and discrimination, household survey. So 66% feared becoming infected from someone living with HIV. Not so surprisingly, this was more in those who live in rural areas compared to urban areas. Likewise, nearly 50% admitted to having some social judgment towards people living with HIV. Again, more common in rural compared to urban areas. And of those living with HIV who were surveyed, 70% experienced some level of stigma, and it was significantly higher in rural areas. When you read of these percentages, you wonder, you know, how have we failed so badly in the last 40 years? But and it just goes to prove that there is so much that still needs to be done when it comes to stigma and discrimination that translates into more effective service provision for both prevention and treatment of people living with HIV. So the health stigma and discrimination framework, as you know, it's a complex thing, and I guess that's an excuse for us not being able to solve this as a problem. It's much easier to design a new antiretroviral pill, I think, or find a cure than to be rid of stigma and discrimination once and for all, because it's so multi-dimensional and multi-layered. So you've got stigma arising from policies, as we know only too well in our region. There are so many laws that criminalize behaviors, from sexual behaviors to sex work to drug use. And so all these public policies that criminalize these behaviors feed into the kind of societal moral policing and the judgmental attitude, and then it translates into stigma and discrimination at the community level. Again, the social environment, religious environment, it adds another layer to it. And then organizationally, many organizations, including government and organizations in Malaysia, and I'm pretty sure in many other countries as well, for instance, still require HIV testing pre-employment or pre-school, pre-university. That it reinforces again that people living with HIV are different and need to be kind of identified early on, lest they infect the rest of the organizations. Then there's interpersonal stigma, and then individual stigma, which the self-stigma that we talk about. So these then drives the drivers are the fear of infection, fear of social and economic ramifications, lack of awareness, social judgment, and the facilitators to this, like I said before, the cultural norms, occupational safety standards, legal environment, which then leads to the stigma experiences and stigma practices and discriminatory attitudes, and the outcomes then become the barriers to accessing both prevention and care. So in short, the three ways in which stigma impacts on people living with HIV or people affected by HIV and at risk of HIV is that it keeps people away, keeps people down, and keeps people in short. So this is again an old survey, but how stigma becomes a major barrier to HIV services. So in this survey, it translated as 61% of people felt ashamed. 61% of people living with HIV felt ashamed. 22% avoided going to local clinic. 11% were actually denied health services, and 7% denied sexual reproductive health services. Rina just mentioned about the denial of health services, including maybe not so overt denial these days, but the delaying tactics, the looking for 101 excuse not to bring them to theatre, I think not so subtle way of denying services to people living with HIV. And there have been multiple papers documenting this, how stigma and health results in health inequities in terms of mental health, leads to depressive and anxiety systems, inability to cope, helplessness, and even acceptance of HIV itself. How it translates in terms of health behaviors is a lower likelihood of initiation of antiretroviral therapy, less adherence to antiretroviral therapy, fewer medical care visits, and lower likelihood of partner notification, which then, of course, ironically, then translates into a barrier for us to have more people tested and limiting transmission of HIV further. The impact of stigma on physical health, for all those reasons, then lead to non-adherence and higher viral load or delay in presenting for care in the first place. Many patients in our region still present with opportunistic infections, multiple opportunistic infections, unfortunately still because of delay in seeking treatment for fear of stigma, because of shame and all those things we mentioned before. So you still have travel bans, disclosure laws, and it intersects with other stigmas. It also leads to risk of substance use disorders, and once initiated on substance use, delayed initiation of treatment. I don't have time to present another study that we've been doing. Our colleagues have been doing at UMMC, looking at the chemsex or and substance use amongst MSM, and one of the in a qualitative study that we did, part of the factors, risk factors for initiation into substance use in the form of chemsex is around depression and self-stigma related to being an MSM. So all this interconnection between self-stigma, societal stigma, leads to substance use, and the vicious cycle that we see. So going back to how it potentially translates into reduction in health-seeking behavior, as previously mentioned, in our region, late presentation is still very, very common, and partly attributed to the high levels of stigma, or the anticipated stigma, the internalized stigma that our patients and people living with HIV in the region experience. So the other thing is, although we are seeing some improvement in terms of the HIV treatment cascade in our region compared to previous reports, we're still some way away. In the first 90, we're at 76% instead of 90, but the linkage to care is also problematic in our region. We're only sitting at 64%, still a significant portion away from the desired 19, of course, then translates to much lower people with undetectable viral load. So all this then obviously impacts on the overall goal to end AIDS. So stigma, as I said earlier, is complicated, it's multidimensional, and there's the whole intersection of stigma, stigma related to race, stigma related to gender, to social class, and of course to HIV itself, substance use, and sexuality, that all combines to make it a complex problem matter to overcome, as it's not just one. In some individuals, you may have all of this intersecting in that one person, and you really need to peel the layers to intervene adequately for all the different stigma, the factors that can then lead to stigma. So you've got internalized stigma or self-stigma, endorsement of negative beliefs or feelings associated with characteristic, and classically translated as I am a bad person because of my HIV. The enacted stigma is experienced stigma or perceived stigma, experiences of discrimination, and I lost my housing because of HIV would be how it can be simply explained. And anticipated stigma is expectations of discrimination in the future. I fear my wife will leave me if she finds out about my HIV. So these are some of the types of stigma, and it may be all of them existing in the one patient. So because of that, because of the intersectionality in the multiple aspects of stigma, interventions or stigma reduction is obviously needs to be multi-level, intersectional and cross-cutting, and importantly, longitudinal. So once-off stigma reduction projects is not really going to cut it, or it's not going to be sustainable. So here's kind of building on that framework that I shared at the beginning, the kinds of effort that needs to happen at the individual level, obviously education, awareness, skills building, coping mechanisms, contact and partnership and support groups are all very, very important, and there are plenty of evidence for each of these kinds of intervention. At the interpersonal level, again, information, skills building, contact and partnership. Organizationally, apart from all those things, there need to be policies and codes of conduct. And then finally, and the toughest one would be addressing the laws and policies, priorities and partnerships that are required to lessen or abolish stigma altogether. So addressing fears, attitudes, institutional environment and experiences, and with that to improve this whole cascade of testing, linkage to care, and eventually getting higher percentages of that 90-90-90 goal. So this is sort of the key principles in reducing stigma, and first try and address those immediate actionable drivers. So I know all of us have been through the 3 or 4 decades been trying to raise awareness as much as we can, particularly in this new era of HIV and the advances in HIV treatment and prevention. I think we need to do much, much more in terms of communicating concepts like U equals U and the successes of the PrEP trials and PrEP rollout. But most importantly, I think the concept of U equals U, because much of the stigma derives from fear of getting infected. Many still view HIV as a death sentence, etc., etc. So perhaps we ourselves need to step up the awareness programs, but couch and to put the emphasis on these new advances such as treatment and prevention. Discuss and challenge shame and blame, address fears and misconceptions about contracting HIV. Yeah, in that National Health and Mobility Survey, close to 50% of people didn't get all the 5 standard questions of, of HIV transmission, all 5 out of 5 correct. So plenty of fears and misconceptions, although fake news, misinformation, disinformation with HIV is not as bad, I guess, these days as with COVID-19. Still, you'd think that after 4 decades, people would know that HIV is not transmitted by mosquitoes and toilet seats and sharing cups, etc. But those misconceptions still exist. And on the other hand, there's also the misconception that in terms of, I'm digressing a bit, but just on this issue of misconception, some people think that there is cure for HIV and they don't need to take precautions. So apart from addressing those immediately actionable drivers, we have to engage opinion leaders and create partnerships, contact strategies. This is something that we have undertaken at the Faculty of Medicine when we got results of that study, which showed that many of our medical students had a high stigma thermometer, if you like, particularly towards MSM, people living with HIV, and people who inject drugs, that we tweaked the curriculum for the early stages of the program, where we bring in people living with HIV, people who use drugs, and we have a whole seminar on gender and sexuality, where we have a speaker who is transgender to come in. You'll be surprised that many, well, maybe not so surprised, that many of our students, when surveyed, say that they've never met anyone who is an MSM or transgender in the past. You know, these very sheltered medical students. So these contact strategies have been shown to be effective, and you know, the feedback that we get on our evaluation of the classes is really eye-opening in terms of them saying, wow, you know, that was really quite educational, that they've, you know, have never sort of, because we don't have, at least in Malaysia, we don't have a very strong sexual education curriculum in our schools. Many have not been exposed to ideas of, you know, gender and sexuality. It's not surprising that they enter medical schools being completely naive about these subjects. So, so some of the things that need to be done are such I just described: models of desirable behaviors, recognized from role models, and then finally develop and strengthen networks and empower and strengthen capacity, particularly of the communities that are affected, and then address internalized stigma. So multi-level, multi-component, and as I mentioned, it has to be longitudinal, and single sessions alone will not lead to lasting change. What's been done, I guess, in the past is traditionally, in terms of trying to implement stigma interventions, it's one clinic at a time, short in duration, few stigma reduction tools, and single level interventions. Where else we need, you know, as mentioned, multi-level and longitudinal. So here are two examples of efforts to try and do that. One is a really very nice program by Bruce Agents from UCSD, I think it is, or UCLA, using the quality improvement modality and approach to reduce stigma and discrimination in healthcare settings. So Bruce has been doing this with a number of Southeast Asian countries. Malaysia has been added recently. Basically, UCSF. So basically bringing people together, so multi-levels, multi-dimensional, and selecting activities at individual hospitals that's been shown to be impactful in terms of stigma intervention, and to kind of scale that up within a QI, sort of using QI concepts and tools, and then to spread it nationally so that you multiply the impact. And so Bruce has been doing this, like I said, in Cambodia, Laos, Thailand, and more recently Malaysia's been added to it. We at UMMC didn't participate in this, in Bruce's program, because we were at the same time, we had just received an NIH grant with, together with Valerie Enshaw as a PI, to do something also in terms of expanding the reach, and not just, you know, single project stigma intervention, but we, instead of a quality improvement approach, we elected to use the Project ECHO approach, using communities of practice and focusing on ID physicians and those more experienced looking after people living with HIV, acting as you know, sort of the hubs, and through an ECHO framework, Project ECHO framework, hoping to disseminate the kinds of interventions nationally through this ECHO model. So we're hoping to roll this out in January. Been delayed a bit with the COVID-19. Other examples, other potential examples of stigma intervention, and this is, I guess, enrolled into service provision is, of course, and I think this is possibly one of the best ways of not just addressing stigma and discrimination, but really turning the model of treatment and care, and that's key population-led services in Thailand, led by Nitya Panupak, and really a differentiated service delivery model, but needs-based and patient-centered, client-centered approach, provided by staff and members of key population communities, and obviously helps with the stigma and discrimination. And some of the evaluation outcomes, it's now contributing to more than half of HIV testing and PrEP services in Thailand. So I think one of the other silver lining of the COVID-19 pandemic is a recognition globally the importance of community-led organization and community organizations delivering services. So hopefully this can translate into better funding, better models of accreditation and capacity building, etc. Because this really would be one way of addressing the pervasive stigma and discrimination in healthcare settings, is to kind of, if you like, we can't beat them, join them. So it's going to take a while, perhaps, to retrain our doctors to be completely non-judgmental, and so it might be easier to upskill our key populations to provide those services instead. And this is an example from Vietnam, where they've also had a key population-led project delivering HIV prevention and treatment for people who inject drugs, and have had really good outcomes in terms of the 1990 goals translated into reduced HIV incidence, as well as achieving viral load suppression. Other examples of, I guess, and this is not so much stigma intervention, direct stigma intervention, but circumventing some of the points where stigma is experienced. So this would be HIV self-testing. This is an example from China. We ourselves in Malaysia embarked on it last year. A web-based self-testing program where individuals can order the test online, get pre and post-test counseling, and then be connected to either treatment providers or PrEP providers once they have had their results. So they will get sent either the oral quick or INSTI HIV self-test finger prick. Now, UNAIDS also came up with this guidance in terms of programs that can be implemented to reduce HIV-related stigma and discrimination. In this guidance, the recommendation was to enact or implement stigma reduction interventions and programs that's based on settings such as community-based, workplace, education, healthcare, justice settings, and emergency. And it's a whole long document that gives lots of examples for each setting and how you could implement this multi-level, multi-sectoral stigma interventions. And I'm not going to bore you with each detail, but it really is quite good. And basically it's a multi-pronged approach, focusing on institutionalizing, for instance, pre-service training in those different settings, curricula, and some of the principles include curricula and training implementation should be led by or fully engaged populations, key populations that are being left behind, and engagement of multiple stakeholders. For instance, if you're going to carry out stigma interventions in the justice system, to really involve not just junior staff, but all the way to senior staff be involved in this training. And so finally, and probably the hardest, would be to address the national level policies and laws that kind of result in the stigma and discrimination and make stigma and discrimination ingrained in many of our settings. These are countries in our region. 37 criminalize some aspects of sex work, 11 have compulsory detention centers, 15 have death penalties, 16 criminalize same-sex relations, and 10 still impose some form of restriction on entry, stay, and residence of people living with HIV. And what's worrying is, I think, all across the region, this growing conservative political environment that could, that would make, in addressing some of these laws a lot more difficult, including our, on again, off again attempt to decriminalize drug use in Malaysia. So in conclusion, stigma and discrimination remain common in Asia and the Pacific, and we've seen sort of multiple examples in real life, even to this day, even as recently, unfortunately, as this morning, the referral that I received, and how it can result in poorer health outcomes, and much less, in our bid to end AIDS or reach the 95 goals. But what can we do about it? There's no magic bullet. It needs to be multi-pronged, multi-layered, and long-term. So with that, once again, thank you very much for the invitation to speak with you this morning.
Thank you so much, Adiba. And I think we have a few questions that have come in. And so what I'll do is that I will address the questions to the specific speakers. And I think at the end, I've got some questions on my own that I think, we can all sort of go into a little bit of discussion for. The first couple of questions are for Dr. Rina. Prof. Rina, what should I look out for as a young PL-HIV as I progress into midlife and beyond?
Thanks, Ching Siong. Can you hear me?
Yes, great.
First of all, I think I want to dispel this notion about this well-being with HIV being something of young and old. And I do think that we really should look at this as a life course perspective. And so for the person who's asking the question now, I mean, it's not to wait till you reach 50. Many things will change from now to then at whatever age you are in. And it's really to build resilience, I guess, in terms of your physical health, your mental health, and your social health. Simple things of adhering to your antiretroviral therapy, lifestyle changes, making sure you have sufficient good diet, exercise, and things like this, having sufficient social networks in place will go a long way. As we grow older, we will experience declines in different areas, and it's really how we deal with these individual stresses. If we are already trying to cope with issues of stigma and discrimination and having multiple mental health and substance use issues, then these are only going to get harder to deal with as we grow older. So it's really looking at the changes that you expect as you grow older as something that is incremental, and you have to work towards building resilience from now and not just when you hit 50.
Thanks so much, Rina. I think since you mentioned sort of stigma and discrimination in your sort of that last part of that response, that kind of flows nicely to this next question, which I think could be both taken by Prof. Rina as well as Prof. Adiba, which is, does continuous stress from living with stigma or experiencing stigma affect people living with HIV's functional health or immune health or immune system in the long term? And I guess, you know, extending that, how do we address it in a holistic way? Yeah, maybe for both of you, what do you think?
Maybe I'll. Okay, sure. Go ahead, Prof. Adiba.
Yeah, I'll just take the sort of the overall what I tried to describe earlier in terms of delay in seeking treatment, you know, delay in or even depression itself, and for some people, suicidal attempts, etc. So certainly, in terms of physical, mental, functional health, you know, the chronic stigma has many impact, but specifically on the immune system, I suppose depression in itself has been shown, right, Rina, to lead to changes to the immune system. So at the molecular immune system level, I'll let Rina answer.
So I think there's some really nice work by Adam Carrico from University of Miami, who's done some work on looking at biomarkers of what happens in individuals who are within the sexual minority group and have substance abuse or substance use issues. And he's shown that in this particular group, you actually do find significant changes in terms of increase in immune activation levels, shortening of your telomere, and there's of course now ongoing work to see how that is then related to outcomes. But I think it's going to be really hard to link stigma, stress with functional decline, because functional decline is it's multifaceted, it's contributed by multiple aspects. It's not just biological, it's genetic, it's lifestyle. And so you're never going to get one study that's probably, you know, definitely going to show that it's linked. But certainly we know enough now that long-term stress, whether in HIV or not in HIV, in fact, even caregivers of cancer patients have been shown to have shortened telomeres because of the stress that they go through. So that bit of it, it certainly contributes to impaired immune system in that sense.
Thanks so much. Maybe just one more question sort of addressed to Dr. Rina as well, which is from an aging with HIV perspective, what can a GP do in our clinic? You know, any experience, any insights into this?
So I was following some of the discussions in the earlier session with Dr. Jarius, and how there appears to be some, I guess, challenges or apprehension about GPs managing, I guess, chronic comorbidities in HIV and perhaps the complications and perhaps drug interactions and so on. At least, I mean, in Malaysia, GPs do manage people with HIV, but not. I mean, it's most of them, at least in our setting. If you're part of a Ministry of Health system, most of them with stable HIV are managed in primary care. So that is extensive. A lot of those with stable HIV are managed in primary care, and primary care physicians, as you know, manage NCDs quite well. The recommendations for managing NCDs are not very different from the non-HIV population, but there are some aspects of drug interactions that you need to address. As a GP, perhaps in the context where you feel you're not comfortable with dealing with non-HIV issues, perhaps the least that you could do is perhaps screening for NCD issues yearly, screening for mental health, sexual health, things that may alert you to issues that then you could then refer the patient for further care at a tertiary center.
Thank you so much, Rina. Prof. Adiba, I have a question that hasn't come from the audience, but it's kind of a question that I, have been dealing with. And, sometimes when we are in this field where we are working for our constituents who are, people living with HIV, and especially when we're trying to fight really hard to combat stigma and stigma at multiple levels and, coming from multiple directions, like you pointed out, some of which may be institutional, organizational, structural, and so on. There's often an argument level against us in the field who tend to be a little bit more how do I put it, with an activist slant, right, that we often seem to be fighting for almost HIV exceptionalism, treating people living with HIV not just, like specially, right, without, other people with other chronic diseases don't necessarily ask for the same kind of recognition or recognition in this way. So what do you think this speaks to, and how do you think we can address it? Do you think it's an important issue?
Yeah, I mean, I think without that early HIV exceptionalism, I think we wouldn't be where we are today, really, because, for those of us old enough to remember how, at the beginning, the stigma and discrimination was even harder. I mean, even in advanced countries, I mean, if you recall, the history of AIDS, when Ronald Reagan didn't utter AIDS for 2 years or 3 years or whatever it was, Mbeki government in South Africa denying that HIV caused AIDS altogether. And I think those, of course, those are extreme examples and extreme settings, but I think without that activism that the HIV community showed, we probably would be in a worse space. So there has to be, I mean, it would be nice to say we could step back a bit on the HIV activism and advocacy and exceptionalism, and move on, if you like. But as the numbers that I've just shared with you show, in some ways the dial hasn't really turned very far. It is precisely because of the groups of people who are at risk or are already infected, who have, there's already inherent stigma and discrimination against these communities, that, it's not the same as someone with diabetes, right? I mean, people don't stigmatize someone for eating nasi lemak for breakfast, roti canai for lunch, and mee goreng for afternoon tea, and then get diabetes, right? They go like, yay, very good, let's go and have teh tarik as well. But in terms of disease causing, it's the same, right? But that's not how it's viewed. So, I am all for the keeping on the activism and advocacy going. The whole HIV exceptionalism issue versus integrating it from a care point of view, I think that's worth debating, because it may be counterproductive in some ways, because we kind of like what Rina was saying, leads to siloed service provision that is not patient-centered at all. So I think from a service delivery, HIV exceptionalism, we may need to review it and integrate the services better for better patient care. But from an advocacy activism point of view, I think we still need to have our voices, our communities need to have their voices still loud and clear.
Thanks so much, Prof. I think what I really hear sort of loud and clear, and which really sticks with me, is what you just said, that perhaps that kind of exceptionalism should not be in the realm of service provision, but more in terms of all of the other non-clinical aspects surrounding HIV. One last question, which has just snuck in under the tape, I think for Dr. Rina, which is that when you talk about frailty, pre-frailty, and this is something I've experienced when I've talked to some of my geriatrics colleagues as well, that even in the field of geriatrics and internal medicine, we've got many tools to assess for pre-frailty and frailty, but often once we've gotten all the scores in, we're left scratching our heads about what to do. So, or rather, it's a complex issue. How do you think HIV and frailty and our management of older adults living with HIV can contribute to this field, and what do you think can actually be done?
Thanks, Shin Seong. And I think you bring up a very, very pertinent. I mean, we also just recently published a paper showing that if you use 3 different tools of frailty, you'll get 3 different proportions and each identifying different risk factors. And I think, yeah, you're right. In the general population as well, there isn't a firm understanding yet of which is the best tool. The concept of frailty is that it's multidimensional. It essentially tries to capture different aspects, a holistic aspect of an individual, from their social links, their mental health support, their physical health, and it tries to account for a cumulative deficit in the patient. And the more deficits they have, the more frail the patient is. In the work that we did, we found that a lot of the deficits came from psychosocial issues, whereas in studies in the general population, a lot of the deficits come from physical health, which means at least by trying to understand what are the drivers of frailty, you can pinpoint, or you can perhaps focus some of your interventions on areas which are most affected in the HIV population. But I agree that we have a long way to go to get to a diagnostic tool where, you just do it and you know exactly what needs to be done. But I think we're still learning from the different studies that we're doing.
Thank you so much. Thank you so much, Rina, for that very measured response. I think that's all the time that we have for questions and answers. So I really just want to extend my thanks once again to Prof. Adiba and Prof. Rina. I hope the time will come very, very soon when, when we invite you to come for a talk, we will also put you on a plane and send you down here, and then we can go and have maybe not all of the roti canai and mee goreng in one day, but definitely try to squeeze in some of that good food.
Sounds like a deal. Sounds like a deal.
Thank you so much to both.
Thank you for having us.
Yes, thank you. Thank you so much. So it's now time for me to close this year's Singapore HIV Congress. I want to thank all of you for attending both days and for staying till the end of this morning and this early afternoon's events. We hope that we've given you something to think about. Just as I did with my closing for the first day, I want to just summarize what we've heard today. I think the first half of our session today really focused around the impact of HIV, the impact of COVID-19 on HIV in the Singapore context. And we talked about how it's affected treatment and viral suppression, thankfully not too much. We've talked about how COVID-19 has forced a catalysm of how we relook HIV service provision in the country, as well as quality of life and the fourth 90, really something that should not be limited to people who are virally suppressed, but across the entire HIV care continuum. Of course, my friend and colleague Chiao Yi presented our very first set of national HIV testing services recommendations. And I just want to remind you that this document, together with the updates and edits to the antiretroviral therapy guidance, as well as the pre-exposure prophylaxis guidance, will all be available on the National HIV Program website after this week, once we've put it up. Then we heard from Prof. Rina Rajasuriya talking about HIV and aging, the current landscape, clinical and service gaps and research gaps, and how we can best go about trying to address all of them. And of course, closing off with Professor Adiba's tour de force look at HIV and stigma globally, as well as regionally, with specific examples from all the work that's being done in Malaysia. Now, all of these talks, especially the two plenaries, left me actually with more questions than answers. And it's something that I want to echo Dr. Daryush saying, right? With health-related quality of life, often we're left with more questions than answers. But I hope you're with me on, realizing that perhaps that's the whole point about talking about these things. We don't have the answers, but we definitely have more answers today than we did, a year ago, 5 years ago, and 10 years ago. And I think that's the whole point, and that's the whole beauty of HIV care and working with people living with HIV and the fight against HIV as a whole, is to keep thinking, to keep questioning, to keep demanding answers, whether we are demanding answers from the science, and that's why we do research, or demanding answers from our clinicians, our doctors, our researchers, as well as our leaders and ourselves, to really push the needle on how we treat HIV and people living with HIV HIV in our community. And hopefully the answer that we get at the end of the day is that we become kinder, we become more compassionate and more empathetic as a whole. We are going to close out today's session with a series of videos from celebrities, influencers, and other allies spreading the word of ending HIV stigma. So in their own way as well, demanding answers from us and the way we think about people living with HIV who may be our friends, relatives, spouses, who live amongst us. Thank you so much for joining us. Before I go, I just want to leave you with the following thought. And until we meet again in 2 years' time at the 2023 Singapore HIV Congress. And that is that as we stand on the brink of a new year, one where COVID-19 still looms large and one where HIV remains as relevant as ever, we must take stock of how far we have come. And we really must be prepared to put in the work to get to where we want to get as well. A world where COVID-19 and HIV may still remain large in our memories and large in our everyday lives, but one where we no longer live in fear of either and how they affect our lives. Thank you very much. I'm Chen Xiong, the Deputy Director of the National HIV Programme, and I just want to thank you again for joining us at the 2021 Singapore HIV Congress.
Hey guys, this World AIDS Day on 1st December, let's not stigmatize, let's not discriminate. Together, we can unite and support those living with HIV. Share how you can get positive about HIV and hashtag HIV positivity in your social post now. Together, we can make Singapore an inclusive society.
Hari AIDS sedunia jatuh pada 1 Disember setiap tahun. Dan tahun ini, saya ingin turut menghulurkan sokongan kepada mereka yang menghidapi dan hidup dengan HIV. Mereka sering berhadapan dengan diskriminasi serta stigma yang selalu dikaitkan dengan penyakit HIV. Tapi tahukah anda, dengan mendapatkan rawatan awal dan yang berkesan, mereka juga boleh menjalani kehidupan sama seperti kita? Jadi marilah kita sama-sama hapuskan salah tanggapan tentang HIV. Ikuti saya untuk ketahui lebih lanjut. Anda juga boleh kongsi bagaimana kita dapat membantu dan menyokong mereka dengan menggunakan hashtag HIV Positivity di media sosial anda.
今天是12月1日，世界艾滋病日，让我们团结一心，伸出温暖的手，支持和关怀 HIV 艾滋病病毒感染者。
This World AIDS Day on 1st December, let's come together and extend our support to those living with HIV. With early and effective treatment, people living with HIV can lead lives no different from others. It's time to get positive about HIV. Are you ready to learn more and shed the common misconceptions? Share how you can be more positive about HIV and hashtag HIV positivity.
With that, this brings us to the end of the Singapore HIV Congress 2021. Thank you, Dr. Wong, for the final closing remarks, and thank you once again to all speakers and chairs for the wonderful discussions today. Thank you everyone here for attending the Congress, and hope all of you had learned some useful takeaways and enjoyed the Congress as much as we have. Before you leave, do take some time to scan the QR code or click on the link posted in the chat box to claim CPE points and leave us some feedback on how we can further improve for our future events. Last but not least, hashtag HIV positivity in your social posts today and join us to end HIV stigma. We wish everyone a pleasant weekend ahead and hope to see all of you again in 2023. Thank you.